Another governing rule is M proportion. It is more related with softwares, not very popular. It, some part of it has been deviated, modified, and used in digital smile designing. But since we are dealing with composites today, I am not going in the software part. We'll be focusing more on the clinical aspects. Just for the theoretical part, the last of them is the aesthetic gauge. These are the gauges which are used by lab technicians and doctors for easy communication. And mostly they are used for ceramic veneer fabrications. In India, they are not very popular, but yes, in abroad, people use them very frequently just for ease of communication, nothing else. So with the theory in mind, now my perspective is it is time to evaluate. हमने किताब पढ़ दी, we have understood it, now it is time to implement it. And we have to evaluate three things: the balance and distractions of facial components, how my smile window is, and in the smile window, either I have excessive or any deficiency of gums and teeth. So coming to the balance and distractions, now these are some celebrities I selected over the net, and you can see them and understand in each picture, there is some excess of facial element which is taking our attention. Like in the middle picture, the eyes are very prominent. In the third picture, the smile is very prominent. Similarly, in the first picture, the eyes have become small and the lips have become a bigger smile, a broad smile. So these are the distractions which take our attention off. And unless we balance them out, the face will not get a balanced view, a balanced appearance. Coming to smile window. The smile window is nothing but when the patient opens the mouth and what is visible inside, the, the lips, that is your gums, your teeth, and your buccal corridor, all that comprises a smile window. Just to illustrate that smile window, we divide the lip line in different categories. The first is the low lip line. When the patient is smiling and speaking, you hardly get to see the upper teeth. Maxillary incisors, only 2 to 3 millimeters are seen. That is where we say it a low lip line. If you get to see more than 3 up to cervical third of the teeth, we say it a medium lip line. And if you get to see the gums also when the patient is smiling, it is a high lip line. Now, what is the significance of these lip lines? A patient who is having a low lip line, you can do anything on the labial aspect of the teeth and you can get away with it. But if a patient has high lip line, you have to have a very good work, very good results, because till gums, everything is visible. And that is why high lip line cases become more challenging than the other two varieties. We also have smile types. We have an older smile type where all the teeth are in one plane and you don't get to see that curvature, what we yearn for. And these are the old smiles where person looks old just because the teeth have become flat. As you can see, the whole occlusion is in one plane. Second is a youthful smile where you get to see those curves, where you get to see the beautiful curvatures, and centrals are more prominent, laterals are smaller, and likewise the whole smile curves in a beautiful ratio. That is the youthful smile. And every aesthetic dentist tries to create this youthful smile for their patients because nobody wants to look old. That is the catch. Coming to gums. Now, gums we have been taught in periodontics, you have to see color, contour, consistency. But in aesthetic dentistry, there is one thing called zenith, which also you have to look for. And what exactly is this zenith? It is nothing but the highest point of the cervical area. That is the marks the highest part of the tooth having junction with the gingiva. That is the position of gingiva when we see smile as a whole. Because if this is symmetrical, you will still get a uniform smile. But if your gums are not even in not in one line, if your zenith is irregular, you will not get that beauty you want to achieve. When I'll show my clinical cases, I'll explain it again. Don't worry. Coming to the teeth, we all love teeth. We are being a dentist, being endodontist. For me, the teeth are most important part. And yes, to evaluate my case, the first thing is the number. Is there anything extra or is anything missing? Based on that information, my treatment plan can change. What is the size? Is it narrow teeth, uh, considering the red proportions, or is it bulky, short teeth? That size you have to ascertain. And the third thing is position, whether they are introvert or proclined, retroclined, crowded, what kind of position my patient is having for their teeth. That you have to ascertain. And based on all this information, my treatment plan comes up. You have to also analyze the crowding, spacing, color, texture, because when we are finishing our composite restorations, color and texture is what patient wants either to be changed completely or to be reproduced exactly as they were before. So if we have not observed all these things, can you understand? Can you think if you can recreate what you have not seen, what you have not observed, what you have not recorded? It's very difficult. I have seen patients many times. They come to me and when they say, I want to improvise my smile, but I want this particular tooth to be recreated this very way. There was one case where I had to spend almost one day to communicate with my lab person, get the canine recreated the same as it was natural, the same cervical to the tip, the canine prominence, they wanted the very same as it was in the natural. So you have to have that vision that yes, what is there in the original, if patient wants, we can recreate, otherwise we can change. But if we fail to observe, can you think you can do justice? No, it is very difficult. Another aspect you have to understand is the dimensions. For beginners, I always say, you take your vernier calipers. Nowadays in market, we even have digital calipers and take down the measurements. There is nothing wrong in taking measurement of each and every single tooth you are dealing with, which you tend to trim or rebuild. You have to make sure that you see what is the original dimension and to what dimension you want to create the new look. Because anything you change, suppose if you change from 9 to 9.2, the central will become more bulky. It will become more wider. Similarly, if your canine is 7.5 and you build it up to 6, it becomes very narrow. It will lose its prominence, it will lose its beauty. That is why it is important to understand the dimensions of teeth before we start shaping them, before we start trimming them. And another part is the contacts, because these contacts will control our embrasures. These contacts will control our mesodistal width of the tooth. And that is why it is important that we deal with them in the beginning. We record them. We make sure that we have not missed out these things, because if you shift the contact, the same size tooth will look either short or will look extra long. When we want to enhance the optical illusions, we can play with them. But where we don't want to have that optical illusion, it is better to leave them as it is. Inclination. You will see a lot of people having midline shift. You will see a lot of people having tilted teeth, but still the smile looks natural and harmonious. But if we want to give something better, we have to see that what exactly was the natural condition and where we want to change it. because your tooth preparations will be dependent on the inclination of the teeth, because any change in the angulation and your preparation will change. Now you can see this picture. All the teeth are having more or less similar inclination. There is no shift. So when I prepare these teeth, it becomes easy for it becomes easy for me to create them again because I don't have to change the angulations. This will also save me from preparing any part of tooth excessively. I will be preparing these teeth uniformly if I have to give veneers over them. That is the importance of inclination, axial inclination. Now with this, there is one catch, and what that catch can be. It is the mindset of our patient. Whenever a patient walks in our chair, opens the mouth, our mind starts calculating. So many veneers, so many crowns, so many implants, so many RCTs, and the financial aspects of it. Yes, that is how our mind works. But what we forget is the mindset of the patient. What exactly my patient wants? Do they want veneers? Do they want crown? They don't want anything, or they want everything? That we have to understand. And a patient may say, I want a smile of Aishwarya Rai or Prati Sanon or any celebrity. But we have to understand, is it really possible? Just to get that set of teeth as that celebrity, but not having the same facial structure, how realistic can be the desire? And the most important, I can create anything for them. But what if they don't maintain it? What is their outlook for oral health? Are they ready to go for oral prophylaxis twice a year? Are they ready to quit their habits of chewing tobacco and supari or pan or whatever? So if they are not bothered about oral health, what can we do? And the most important, what is their attitude towards us? Do they take us for granted? Yare, dentist hai. Or they look to us with dignity that yes, doctor is there to help me out, to give me something better off. All these points are very important because this will help us in getting to the root cause. To plan a treatment, we have to have preparation. And before we jump to any conclusion, before we open our mouth to the patient, that Mr. So and so, you need 6 veneers, 7 veneers, 8 veneers, depending on your treatment plan, you have to understand do the do the patient needs a pre-treatment procedures of periodontics or mild orthodontics or directly they want veneers. What suits them the best? So before telling to the patient, we have to have clarity on our own mind that yes, this is the sequence. First, I will be addressing gums, then I'll be addressing mild crowding or spacing, reducing it or modifying it to my benefit, and then I will go for veneers. Or I can jump to any procedure and I can straight away take away on the preparation of teeth. I have seen a lot of youngsters making blunders here, and the blunders are they fail to communicate. Indian dentists lack in one thing that is documentation. Because in our college program also, we are seldom taught by our teachers to take pre-operative pictures. Because patient will always say, ये तो ऐसा नहीं था, पहले ज्यादा अच्छे थे, आपने खराब कर दिए. So we have to take pre-operative pictures. We have to make the record so that we can tell them, see, this is where we started from and this is where we are. And you have to make sure that patient understands the steps involved. I remember my starting days. There was a patient I explained them that these many teeth will be required to be shaped and given veneers. But when I started trimming and I showed them after preparation that, see, are you happy with this size? And they were shocked. And they started quarreling. Doctor, you have not told me that you will be trimming my teeth. Doctor, you had not told me you will trim so many teeth. Doctor, you had not told me my teeth have become smaller. It becomes important that we tell them that, see, these are the steps you will be following, these are the steps you will be seeing, and for that, the mind has to be prepared. Otherwise, what will happen? In the middle of the procedure, the patient will panic and then you are gone. Sometimes patients are apprehensive. You need to show them the final result even before you touch the teeth. You may do Photoshop, you may do real-time build-up, you can even use your composite to just give them a brief glance that yes, after finishing this broken tooth will look like this. After finishing the procedure, your teeth may look like this. And that helps patient to understand our vision. Today, there are so many softwares to do this work, but my approach is to make it minimal cost effective. I mean, as a youngster, when people are struggling with getting patients to the clinics, I'm not talking of seasoned players here who already have established practice, where they can put money in lot of gadgets, software, this, that, scanners, everything. But a person who is starting practice and who wants to earn a good money by doing aesthetic dentistry, we have to get to the basics. Not everybody can invest straight away in all these things. So you have to be able to give them a real-time build-up. You can play with composites with that, do a fast mock-up and tell them, see, this is what it looks like after finishing. So all this, if you do, if you communicate, patient will develop trust in you that yes, my doctor knows what he is doing. Sometimes there may be need for temporaries. This is especially important when you are doing ceramic veneers. Today we are talking about composites, so this point is not very important to us because everything is going to be in one sitting. And the last but not the least is the budget. When you tell the budget, okay, so many veneers I'm going to do and this is going to cost this much. So you can see the look of the dog and the cat. The cat is the patient and dog is the doctor. You can see the reaction when they hear the budget. Because unless you give them the final picture and the cost involved, don't think they will be happily giving you the money for your efforts. So you have to have the clarity of your own vision that what all you are going to do. You have to have clarity of communication that this is what I'm going to do to the patient. And you have to have the clarity of budget and cost involved that see, this is what is going to cost you. A set of 6 composite veneers, this is going to cost you this much money. If you are not able to tell your patient, you cannot expect them to pay you back. Many youngsters I have come across, they tell me the same thing. Sir, we started doing work, but we forgot to tell the patient what the charges will be. And then either they left our clinic without paying or they just paid what they felt like. And then we felt being used. And that is not a very healthy feeling. So it's always good to tell the patient the final treatment cost and your fees. If there are any hidden costs, you have to tell them before. Because if some in the middle of the procedure, you realize the patient is high-fi, good paying, and they and then the mind changes. Oh, I quoted 10,000 in the beginning. Now let us bring it to 15,000. Tell the patient there are some additional hidden costs. And likewise, what will the patient think? They will not think healthy. They will not take it in good way. Because for them, the initial amount what you have told was the final amount. Any hidden cost, if there are, that is the burden of the dentist. If you tell them any additional charges during the procedure or post treatment, forget it. You are just going to spoil your reputation. You are just going to spoil your repo and you are going to lose that patient and all the references which he or she would have generated to you. So no hidden cost should be there. No surprise bombs should be there to the patient. Whatever is there is to be there before you touch the teeth with your burrs. So let's go ahead with our topic of the day, aesthetic dentistry with composites. And the scope is unlimited. You have anteriors, you can do class 3, you can do class 4, you can do diastema closures. And not just that, even for posteriors, class 1, class 2, inlays, onlays, wherever you can improvise the existing condition, it is aesthetics. It is aesthetic dentistry. Somebody may ask, why composites? Why not any other material? Reasons are very simple. It is economical, it is easy to perform, it is more predictable because the control is in your own hand. Life is pretty long, but for our composites also, if anything lasts 3 to 5 years, 6 years, it is good enough. And your composites have multiple use. You can use it in any situation. You can use them for templates, for your ceramic veneer. You can use them for mock-ups, for build-ups to show patient. You can even use them for repairing of ceramics on urgency basis. So sky is the limit. You have to think about different applications, and that is why composites have become so popular. To go on the scientific side, there are always some ideal requisites. Every material, whether we use sealer, whether we use composite, whether we use ceramics, whether we use anything, we always make a list of ideal requisites. That is how the science works. We want the best of the properties and low shrinkage, good handling properties, high polishability. These are all wannabes. I want a composite which fills at least majority, 70, 80, 90% of these, if not 100%. That is what is my desire. And over the years, I have also seen a problem which is called shade selection. How many of us take it as a big dilemma, a big challenge to do a good shade selection? Because if your shade is right, then everything is right. If your shade is not right, then you are in the soup. And why it is so? Because sometimes your tooth is having more than one shade, it is multi-layered. There is a difference in refractive indices. Your operative light is the same old halogen lamp. You may have a lot of destructive surroundings. A patient, a lady patient who has put heavy makeup and has come for composite restoration. There is again lot of distractions around. And the color saturation of the eyes. Our eyes cannot see a color more than few seconds. In 3 seconds to 5 seconds, our eyes get saturated with one shade of the color. We cannot differentiate the second shade immediately after that. And of course, the shade guides which we have seen over the years, they have become very complex. You get to see multiple shades, so many shades to choose from, and these multiple shades also compel us to have a big inventory. More the number of shades, more the composite you have to take, more is the chance that they will get expired because you will not get regularly the patients of all the shades. You may get one or two shades more, and one or two shades will always be lying there happily and getting expired. So, what are the solutions? For getting the eyes out of the saturation, you can stare it on a blue object for a few seconds. You can use your scanners or you can use intraoral camera for better shade selection. You can minimize the distraction by asking patient to remove that dark colored lip gloss so that you can see the natural shade of the teeth. You can even modify your preparation for this very same reason and use a composite system which has lesser shades and which fulfills the need of multiple shades at the same time. I even advise people to use multiple light sources to see that metamorphism, chairside light, camera light, different types of light sources. You can easily come to know that yes, this is the most acceptable shade and this is what I have to take for the patient. And nowadays we even get the color corrected lights. These are the special lamps where you get the true light. You can get them on Amazon also. And you can use them for having the right light where you can have surety that yes, you have taken the right shade. Over the years, I have used multiple composites and now I have come to a one composite which gives me maximum happiness in the form that it fulfills my list of ideal requisites. It gives me good handling. It gives me good polish. It gives me less of the shades to play with and with more versatile outcomes. I can mix and match very easily because these composites have a dual shade property and which gives them that enhanced edge that with less number of tubes you can get more results. Just to highlight some features so that you know what I'm talking about. As you will see in the demo, they have very good handling and adaptability. There are 7 shades for maximum of your cases. 90% of cases you can finish off with the simple collection of 7 shades. For 10%, you may use other shades available from the company. And same composite you can use for anteriors as well as posterior. You don't have to have a separate composite for posterior again, thereby minimizing your inventory. Now, if inventory is less, definitely you are going to have less material to play with, and the chances are you will use it completely rather than getting it expired and wasting your money on buying new syringes. So these are the advantages which made Brilliant Everglow my favorite composite. Just to give you the idea of the shade guide, now the first picture you are seeing is the international shade guide, where they have encompassed all the available shades in one place. And second shade guide is the Indian shade guide, which you get in the kit. And you can see just 1, 2, 3, 4, 5, 6, 7 basic shades and one enamel universal. And this will fulfill your 90% cases. Those 10% cases will require additional syringes, which you can buy separately. So with this simplicity of shade guide, don't you think playing with composites, giving good results to the patient has become very easy? Yes, definitely. Now, this is a list which I tell to all dentists that when you are doing aesthetic dentistry, you need to have all these things. You have to have calipers, your verniers, you have to have burrs, you have to have good instruments, brush, yes, definitely. Different bonding systems, composites, paint on colors was available recently, but now it is not. So even without that, we can play with the composites and give a good result. You have to have good finishing and polishing kits. And most important is a camera, a high resolution camera for photography. Because as I said, we are not trained most of the time to do good documentation. And no work, no matter how good it is, if you are not able to record it, it is not going to make the impact which you want. So, with all the theory behind, coming to the next step of the lecture is preparing the teeth. How many of us find this step challenging? I see a lot of people asking me, how should we go about? How should we prepare the teeth? And in the coming slides, you will see how to go about. As I said, to give something out, you have to have right tools. You have to have right armamentarium. So if you are having the right burrs, definitely you can deliver. But if you don't have the right burrs, how can you deliver? That is the question. So whenever we are doing a composite veneer, the first step is the depth cut. Now these are the special burrs which have a definite thickness of these rings, 0.3, 0.5, 0.7, depending on what type of preparation you want. Because the minute you will sink them on the tooth, they will give these bent-like preparations. And the beauty is, since the rings of diamonds are having a definite thickness, it will not trim the tooth beyond it. It will not trim the tooth beyond it. That's why these burrs play a vital role in controlling thickness of your preparation. The second step is label reduction. You take your chamfer burr and prepare the teeth in two planes. First, you do the incisal third and middle third reduction, and then you do the cervical third. Here also the starting point is the center of the tooth. From center we go to the proximal, not vice versa. Because when you are going from central to proximal, you get a better control. For beginners, this is a tip that if you go from central to proximal, you tend to have less chances of slipping the burr, damaging the adjacent tooth. Otherwise, what happens? Patient has come for one tooth and you end up doing three teeth. Patient has come for one central incisor and you end up trimming adjacent lateral, adjacent central, which should not be. So the first picture was the middle third and incisal third. The second picture shows the cervical third. All these preparations are to be done from center to the proximal, center to the proximal. And that is how you get that curvatures maintained. Otherwise, what will happen? The tooth will become flat. And if it becomes flat, it will lose the aesthetic value. Just to illustrate further how I'm refining my proximal part. With the bulk reduction was with the full length of the burr, but when I'm going the proximal, it is only the head of the burr which is working. So for beginners, I would say you start practicing on the cast. Instead of taking typhos, holding them in teeth and trimming them, you take your plaster models and you take the same exercise. You can prepare the teeth and see how they are shaped up. Once you have done the labial reduction, next is the incisal reduction. You can use the same depth gauge burrs to the incisal reduction, or you can use your chamfer burr also, whichever you are comfortable with. But if you have good control over the tooth, you can use your chamfer directly. Otherwise, I would prefer to use your depth gauge burr so that you know how much you are trimming. Otherwise, what happens? You trim up excessively, the patient lands up in sensitivity. Instead of veneer, you end up doing root canal, you end up doing a crown, and the patient gets spoiled because what you have promised, you are not able to deliver. And one clinical tip I would give here is whenever you want to trim a tooth, always take radiograph because sometimes the tooth may have a deceptive look. You may feel, oh, it is just a central incisor, and I may not touch the pulp horns. But sometimes pulp horns are excessively long, and then the minute you trim the incisor ledge, and sometimes the horn gets involved, and the patient starts getting sensitivity. I had one case where I had done the same mistake. I trimmed the teeth, thinking that I'll give good veneers, and next the patient came with severe sensitivity. So in the same budget, I had to do root canal treatment for the patient. I had to give her crown over the sensitive tooth post root canal treatment. And eventually my whole treatment plan got spoiled and even the patient got lost. So I learned from my mistake. Whenever you are planning to trim a tooth, no matter how small the reduction is, always take radiographs. Just get the idea, the position, shape, size of your pulp chamber also. Once you are done with all this, then any overhangs, any unsupported enamel margins, any unsupported enamel rods, you should be able to visualize, you should be able to remove because these overhangs are the center of weakness. They will break under the restoration, they will create gaps, they will become center of secondary caries, they will become center of sensitivity, all the problems. So it's better we remove them right in the beginning. You can use a small head burr also for the purpose. Just make sure there is nothing weak, nothing overhanging, unsupported. Everything left over should be well supported. The same preparation from the inside, from the lingual aspect, palatal aspect, you can see how my burr is taking care of the incisor ledge from the inside, giving a small bevel. The idea is that my incisor ledge, if I have prepared, and when I restore, It should not get a bulk of composite. It should be blending smoothly with my palatal surface. Otherwise, patient will say it is bulbous from inside and their phonetics will change. If incisal edge is prominent from inside, the phonetics will change. Patient will not be happy about it. Once all this is done, you can smoothen up your preparation with a medium grit or smooth burrs used for polishing just to see that all preparation is smooth, the transition is even, there is no sharp bend, there is no acute angle in the preparation. It is a homogeneous, uniform preparation. Always, always look incisively. Put your mirror under the prepared tooth and see your preparation in the mirror. By this, you will get to see the angles, the transition angles, your proximal line angles, how they are. Are they prominent? Are they very much rounded? Are they sharp? Or we have to shift them towards midline. All this you can assess only when you see it incisively. If you are doing multiple teeth, if you are doing multiple teeth preparation, even then it becomes important to see in the mirror how the teeth are looking. Are they symmetrical? Two incisors I have prepared, and if they are not symmetrical in preparation, can you think I'll be able to restore them in the same proportion? I cannot. So to build up two teeth in harmonious way, in a balanced way, it is important that you assess your preparation in indirect vision and see if there is any discrepancy. Are they looking equal? If there is any overhang, if there is any sharp angle which need to be addressed, and that is why this picture is very, very important. And that is how your finished preparation looks: smooth, round, with even transitions, no sharp bends, no sharp angles, with well supported enamel rods, well defined margin. It looks beautiful. It looks beautiful. Now, depending on different situations, there is no universal tooth preparation for a veneer. Surprised? Yes. For different type of situation, I have different types of preparations. How? You may have teeth with open contacts or diastemas. You will have a definite type of preparation for them. Then there may be teeth with close contact, which are touching each other. You will again have a different preparation for them. Then there is something called edge ending, where I don't want to involve the incisal edge of my tooth. And then there may be a preparation like I showed in the picture, edge overlap, where I'm trimming the incisal edge and I'm going beyond on the palatal side. So these four type of preparation you will see in maximum of your cases. Just to illustrate, coming to first, the open contact. Now this is a case where patient already had lot of diastemas. So I was having enough of space to leave my proximal margins till middle third. There was no need for my preparation to go towards palatal side, like what you say, 3/4 jacket crown or overlapping type on the proximals, wraparounds. So I could leave my margins right in the middle third. Sorry, sorry. So this type of preparation is good for open contact cases where you have a lot of diastemas. Just to illustrate again that this was the case. And I have used the depth gauge burrs in different directions, horizontal, vertical, to give that initial depth feeling that how much I have to prepare. Partial preparation, just the centrals, half part of the central incisor I had prepared. And that is after complete preparation. Now you can see the margins. If you can see here, the lateral, the margin is very much till the middle third of the proximal. It is not going palatal. So that is what I mean by open contact. Another preparation is close contact, where you can see now the two centrals, they are in close proximity with each other. So now, if I want to change my contact, listen carefully, if I want to change my contact, then I may take this preparation to palatal side. But if I am happy with my contact and I don't want to change it, I can leave it as it is. I need not break the contact. So again, why I said in the starting, check your contact area. Check how the teeth are in contact with each other. Because based on that information, I may or may not open the contacts. So for close contact, it is my choice whether I leave the margin touching to the adjacent tooth, or I open it up, I take my preparation to the palatal to make it a wrap around preparation like a 3/4 jacket crown. So that is about the close contact. The third is edge ending. Now this is a case where incisal edge was good enough. Patient was not willing to change the length of the teeth. So when the length is not going to be changed, what is the point in trimming incisal edge? As you all remember your dental anatomy, incisal edge is the strongest part of your central incisor. And if you can do a preparation without damaging it, nothing is better than that. So here my finish line is labial. It is not on the palatal side, it is labial. It is ending right at the incisal edge here without damaging this thick bulbous enamel rods. So from cervical to incisal, it is edge ending with I have ended my preparation at incisal edge. That is edge ending. And then the most common is edge overlap. As you can see, the patient wanted length to be changed. And in this case, I had done both upper and lower preparations, not just the upper. So we had trimmed the incisal edges also, we had gone palatally. But here also I was happy with my contacts. So I had again not opened them. I have kept my margins in proximal to each other. So these are the four types of preparations we see in our daily cases. Most of the time it is a combination. It may be one type, it may be a combination of the types, depending on what type of case you have, what type of result patient wants. Now this is a small video done on the model which we are going to use today, just to show how the teeth have been prepared. One tooth I have prepared for you. This was the case. Now this is my depth work, and you can see I have first assessed. Initially, I thought that it's better to use without water, but then there is always a risk of damaging your handpiece, damaging your burrs because of the dust accumulation. So we started with the water, and that is how we start. In one stroke, we have to go. Never, never, ever lift your burr while you're trimming. Make it a one go, one stretch. Because if you will lift burr in between, you will lose the track. And you can see it should always be in one go, otherwise you will just lose your track, you will lose it. And I will show you here what happens if I go beyond the depth of the burr. If I want to trim beyond the depth of the burr, you can see the markings. Again, I'm using it just to trying to go further deeper, and you will see is dark colored scratch mark coming, how it comes on the preparation. Now this indicates I have reached the depth of my depth burr. I cannot use this burr further to go further deeper. If I want to go further deeper, I have to use a bigger depth burr. Changing my burr to the chamfer, now you can see since I have control, I can start from the proximal, but for a beginner, it is always better to start from the center. Thereby, you reduce the chances of slipping. I am doing the incisal and middle third first, and then the cervical. And you can see the burr moves from mesial to distal in one stroke. I'm not lifting it because if I lift it, I lose the focus, I lose the flow, and that is how it should be. Now, this is a closer view which I had done under my microscope. Just smoothing the blending so that all the preparation is in one plane. Your labial plane and your cervical plane will be different because the tooth is having a bulbous appearance. If you make your cervical to incisal one plane reduction, it will become flat. And once it becomes flat, it loses the beauty. So whenever you are doing reductions, always try to maintain that bulbous shape of the tooth. Never, never, ever change it unless your adjacent tooth is also flat. So you can see how easily we can trim we can go ahead, we can do the trimming, we can maintain the proximals. Now this mounting is having slight gaps. There is mild diastema, but we are not going to build up the tooth for diastema purpose. This tooth today we have selected more for shade change because initially it was having more of fluorosis spot and the adjacent tooth is having less of the fluorosis spot. So my view is that just to give you a basic idea of the layering of the composite. Margin also, people ask me what type of margin you want to keep for the preparations. Many people say we want to go subgingival. Many people say we want to go equigingival. But I always say, check your case. Is it a low lip line? Is it a high lip line? Or is it a medium lip line? Because when a case is medium lip line and even with biggest mouth opening, wide smiling and laughing, you cannot see the cervical third of the tooth. You can easily prepare the tooth with a supragingival margin. You need not touch the gingiva. But if the patient is having a high lip line, you cannot leave margin supragingival. It has to be equigingival. I don't give my margins subgingival for the very simple reason. One thing, it is difficult for us to finish them, give them smooth luster. And secondly, for patient, it becomes difficult to maintain them. Eventually, it causes inflammation, it causes recession, and leading to destruction of the beauty. Now, this is a smooth grid burr just to smoothen off my preparation and remove our overhangs. I'm just refining my preparation to make sure that there is no abrupt transitions and it is a homogeneous preparation from right to left and from incisal to cervical. Maintaining the cervical bulge of the tooth, maintaining the curvature of the tooth. Now, this is the label reduction I have done. And just on second thought, now we decided to give overlap kind of preparation, incisal overlap. So instead of using my depth gauge, I'm just showing you how the reduction has taken place. And now I will be preparing the lingual palatal surface of the tooth with my chamfer burr. I can use the chamfer burr or I can use my other burrs for the very same purpose. But whenever you are doing it, make sure that you don't do more than 2 millimeters. Otherwise, you will just extend your preparation excessively on the palatal side, which will be difficult for the patient later on. Now you can see how I have done the reduction and the transition from palatal to labial. If you compare the length of the teeth, you can see that 1 1 is longer than 2 1 because this preparation I had done to make it incisal overlap. Sometimes it is difficult to use all the three death grooves. So in that case, you can use maybe only one. You use one or you use three, depends on you, on your ease of working. But I'm just trying to show you how it is going to be like. So things may not seem as easy as it looks on the pictures, but when you do it live, when you do it on cast, then you get to see the difference. just to blend in, just to do the slight reduction further so that I know that I don't do it excessively over jealously. And again, with my same chamfer burr, I'm doing the palatal refinement, modifying that bevel, smoothening of the margins. And since it is a model now, you can see how the transitions are, how the bevel has been given, how the label side has been prepared, how the proximal margins have been placed. All this, I can hold it in the hand and I can see it directly, but when it is in the patient's mouth, all this information I can see only in the mouth mirror. And wherever I see discrepancy, I can just do the refinement. Now you can see here how much I have done on the palatal side, not more than 2 millimeters. And that is just to incorporate the incisal edge in my preparation, nothing else. So that is my preparation for you today. On this, we'll be working on the build-up. After the lecture, on the same model, we'll be doing the composite build-up. The objective of today's mock exercise is to make it as close to the adjacent central incisor as possible. Still, if I feel you can see some pointed angles, I can just round them off because these pointed angles will create problem in the later on. Both sides I can do slight trimming. Yes, that looks beautiful now. Always make sure there are no sharp angles, the transitions are smooth. And once you have done the preparation, examine from all sides, from labial side, from palatal side, from proximal side, and make sure that yes, everything is in right order. Because once you start doing build up, there is no coming back. You cannot modify your tooth preparations once you are starting your composite build up. Coming to something interesting, I always like James Bond for the very simple reason he gives me that feeling of power because my composites are nothing if I don't have a good bond. But the question comes, is there a universal bonding system or is it tissue dependent? So when I am using only enamel for my preparation and my build up, I'll do etch and rinse and conventional fifth generation bond. But if my preparation has gone in dentine, then etch and rinse will not be that effective. What I need is a self-etch seventh generation bond. And if by chance I have gone further deeper, I have gone to the cementum in case where there was gingival recession and the patient wanted something to be done there, you may find your composite to adhere difficult because the cementum is not a good substrate for composites. So there you may need a bilayer technique where the base is of a resin modified glass ionomer and over the top you are going to use self-etch bond and then build up with composite. So always remember what type of substrate you are having. Based on that, you will select your bonding system. Going to the basics, because sometimes it is the basics we forget. We always remember the advanced things, but we forget the basic part. And it is always etching, washing, and drying. When you are etching, you have to make sure you apply to 15 to 20 degree, 15 to 20 seconds. If you are doing an enamel, you have to dry, but Don't blow dry, make it blot dry. Use a blotting paper, use your tissue paper and blot dry. And then you apply bonding system, spread it over, and you can even check with your three-way syringe, chip blower I would prefer because three-way syringe will have oil and that oil will disrupt your bonding again. So it is better to use a chip syringe and see that your bonding system is evenly spread all over. And once it has evenly spread all over, there is no pooling of the bond at any one place. Then you can do light cure and do a composite buildup. But at any given time, if you see the truth has lost its isolation, you may have to come back to the step one. You have to again isolate, again etch, again wash, again dry, then bonding system, and likewise. Similarly, if you go to a seven generation bonding system, especially when you are targeting dentine, it is always isolate and dry with your blotting paper, apply bonding system, wait for 20 seconds, 30 seconds, let that bonding system sink in. The idea of waiting is to let that bonding system sink in your dentinal tubules and make those beautiful residue tags which you only see in your scanning electron microscope pictures. Once that time period is over, blow dry again to remove any pooling of bond and light cure. Whenever you are doing composite, I have seen people always in rush, always running, always trying to do things in haphazard way, in fast way, trying to cut down on time. Arey Baba, we are doing something with beautification. We are dealing with aesthetics of the patient. What is the point in hurrying? Take your time. Rushing will not help. Take time. People ask me, what type of composite instrument should we have? Can we use our cement carrier, what we have used in college for the same? The answer is no. Because maximum time, the problem which we have seen over the years is most common problem. Composite pulls up. We have placed the composite and then when we are adapting it, it pulls with our composite instrument. And that is why we don't recommend any Tom, Dick and Harry, any instrument just like that to be used for composites. If you use a good quality instrument, the problem of pulling the composite back from tooth, pulling back from the tooth, spoiling the adaptation, spoiling the shape we are given, minimizes. So always make sure you use good quality instruments. And these LMRT instruments, I have used them. They are very lightweight. Being lightweight itself gives them the power that you can use them for a longer time without having fatigue of your fingers. Plus, the handling improves. The composite doesn't adhere to them, and you can use them for a long period of time. These are the pointers which I give to youngsters. Your quantity does matter. Now, the same type of preparation, in one increment, I will have one shade, and in another increment, I will have another shade. Why? Because the minute you take a thicker increment, a bulk, your color index will change. All shades are controlled by thickness. So if I want very white teeth, I can use a thick layer of A1. And if I don't want that high whiteness, I can use a thinner layer of A1. So based on how much thick my composite layer is, my shade can change. So people who complain, मैंने shade selection किया था, I had selected it the right way. My shade selection was perfect, but even then, after doing my composite, my shade has changed. What went wrong? Your thickness went wrong. The amount of composite which you had taken for buildup changed the shade. So that is why your thickness becomes important. And secondly, the layering pattern. If my tooth preparation is flat, it is not rounded, it is just flat surface, and I put one chunk of composite over the top, it gives me a chiclet appearance. Those chiclet Bugs Bunny type. But if I do incremental buildup, The same syringe will give me a polychromatic effect. On cervical third, it will give me a different shade. On incisal third, it will give me a different shade. And how you are doing light curing will also decide your life of the composite. How you are doing your light curing will also decide how much discoloration of margins will happen and how much it will not. Surprised? Yes, that is a fact. I'll explain it again, don't worry. So when you're doing a single layer preparation, you can only get a monochromatic effect. Sorry. But if you're doing multiple layers, then you will get that chromatic effect, photochromatic effect, where the base layer is different, top layer is different. That is the idea of multiple layers. And when there is a complex matrix, okay, a tooth is having multiple shades inside, then you have to use it in a different way to give a complex matrix to recreate what was original life. And that is why I always find single tooth restorations are more difficult than doing six teeth or two teeth. Because when you're doing two teeth, you have made two teeth similar to each other. When you're doing six teeth, you have made six teeth more or less similar to each other when it comes to shade, not shape. Shape will be individual, but shade will be more or less same for all of them. But when it is a single tooth, that is the most challenging part. And staining. Sometimes you may have stains. Patient may want the same stains to be recreated. Then staining is advocated. And nowadays I have made it. If indicated, I always try to brainwash the patient to have a better smile design rather than targeting only a single tooth. Because sometimes you will see if you do a single tooth, it will not give that impact compared to when you're doing six teeth or eight teeth or 10 teeth. I remember that TV ad of Bajaj where they said, "Pure ghar ke badal dalunga." Similar is the condition with our work also. If you are doing a single tooth preparation, it is a difficult thing. But if you're doing multiple teeth at same time, it becomes comparatively easy and better results. For me, what is more important is to give better results. Just to summarize, layering pattern, it is always first the opaque layer, then the body shade, and then the sandwich of colors. And over the top, enamel shade or body shade, whichever is needed. But to do this layering pattern, make sure of two things. What are they? The first thing is you have prepared sufficiently to receive so many layers. Mark my words, you have prepared the tooth in such a way that there is space available to incorporate all these layers. Got it? Because if space will not be there and you build up all this, your tooth will become too bulky. And when you will start finishing and polishing, you will end up removing top two layers and reach to opaque layer. And then the problem comes. What happened to the shade? What happened to the shade? So your preparation will decide what kind of layering pattern you have to follow. And second thing is thickness of each layer. Thickness of each layer again will play a vital role because any layer, if you make it excessively thick, will eat up two things. One, it will eat up the space for the top layer, and second, it will eat up the effect of the bottom layer by making itself prominent, by making itself more prominent. And that is why your preparation thickness and your layering thickness both play a vital role. I was talking about the light curing. Whenever you are doing anterior teeth, the first layer of composite you have placed, my personal recommendation is do the curing from inside, like how it is in the first picture. Even if you're doing for the lower teeth, do it from the lingual aspect. Never, never, never do the first curing from the label aspect. As I said, if you're doing a bulk filling, if you're doing a thick thickness, it will not give you the good results. If you want good results, you have to do the incremental buildup, be it anterior, be it posterior. And at the same time, when you're doing light cure like this, it is absolute no. Why? Because composite shrinks towards light. And if you're doing the first increment curing like this, it will pull towards the light, it will leave the surface behind, and it will lead to post-operative sensitivity. Many times people have come to me from other practices that we got filling done and then patient and the tooth is having sensitivity, we cannot eat anything from it. The first thing comes to mind is, oh, it may be a root canal tooth. But when I see X-ray, I realize that it is a normal restoration without indication of root canal. And then I realize what might have gone wrong. And immediately the thing comes to the mind is opening of margins. And this opening of margin happens if you do light curing straight way on the top. So whenever you are doing a composite restoration, the first layer has to be pulled towards the tooth. And that is why and in the molars or in the premolars, we do it from buccal or lingual side so that the material pulls itself towards the tooth, thereby sealing the margins, thereby minimizing the chances of post-operative sensitivity. Once you are done with the first increment, then you can do the same from the top or from the front. That is okay. But the first layer curing makes or breaks your post-operative sensitivity. And to do good light curing, you need a good light. If your light is not powerful, don't think you will be able to do justice to the patient. And I always recommend get your lights checked with light meters for the intensity. Because over the ages, I don't remember when I had purchased my light cure unit. Maybe I can remember with if I see the bills, but I don't remember how many working hours I have spent with the light. And if over the period of time my composite has stuck on the light tip, this fiberglass tip, if you see, most of the time your lights will be having some or the other composite getting stuck to it, the intensity will change. So always keep your lights clean, always keep them checked. At least once a year, you can ask for a light meter to get the intensity checked. And yes, if your light is strong, you can even cure 2 millimeters easily. Otherwise, if the light intensity is less, you will see that even 1 millimeter thickness is getting difficult to get cured with. So a powerful light like Spec 3 is what I recommend because these lights are universal for all types of composites. I have seen lights which are compatible with one type of composite system, but they are not compatible with other composite systems, and that is a big mess. That is a big mess. You need a good light which is powerful. You need a good light which is universal, happily curing all types of composites, all brands of composites. Once I have done tooth preparation, once I have done build up, once I have done curing, now it's time to do the finishing and polishing. Because unless I do the finishing and polishing, I will not get the desired outcomes. It is always in multiple phases. The first phase is the cross contouring, where I get as close the desired anatomy as possible. Once I get the shape right, then I do the reduction and smoothing to make the surface more polishable, more smooth, more shiny. And once we are done with that, then we can go for The tertiary anatomic features, fine details of the teeth. If we have recorded them in the starting, then we can think to recreate them. So it is always in three parts: gross contouring, smoothing of surface, and then giving the high luster. And for that, you need inventory. You cannot do anything just like that. You need burrs, special burrs are there, polishing burrs. You need cups and cones. You need abrasive containing brushes. And nowadays, you even get special polishers like shape guards. So these are the inventories which we need. Coming to the burrs, these are the special smooth grit burrs, yellow bands on them for making gross reductions. If I have built up my composite like a block and I want to recreate the anatomy, I cannot use my preparation burrs. Mind it, because those burrs are having coarse diamonds which will cut more than expected. So when you are going to reduce the bulk of the tooth, you need burrs which are having yellow bands, which are polishing burrs, so that you do very selective reduction. Otherwise, we'll keep on building, trimming, not getting the right size in one go. Then you have cups and cones. These are the Kenda cups and cones. Different colors indicate different grits. From pink to green to white, you start with pink, then to green, then to final finishing by white. And these cones, you can easily maintain your contour. Cervical third, you can easily polish with them. The same cone can be used for cervical as well as incisal and middle third without changing the contour of the tooth. That is the beauty. Otherwise, if you use any other shape, the chances are you will flatten up the tooth. You will lose the beauty which you had created by doing those incremental buildups of the composite. So make sure that you have the right inventory and use them the right way. These are the abrasive containing brushes. Most of the time we use it to give the final luster and to final gloss of the restoration. You can use brush, you can use cones, any shape you want, you can use as per your requirement. And then you have the polishers, the shape guards, as they call. You have different colors. You start with one color, and the last color to be used is the green color. You start from coarse and you end up with the fine finishing. The beauty is that they don't tend to change the shape of the tooth. With great difficulty, with great efforts, I had created those contours. I had created that cervical bulge. I had created those round curves of the tooth. And what happens if my polishing agents destroy them? It is devastating. So you have to be sure that whatever polishing agent you are using, it doesn't alters the anatomy you have created for that tooth. Never should that happen. By changing the angles, you can use the heads, you can use the flat surface, you can reach out even in the proximal part of the tooth without the risk of opening the contacts, without the risk of damaging the adjacent tooth. So you have to open the mind. You have to understand that yes, to give good result, you need good inventory. Otherwise, you will get stuck. This is one starter kit from Coltene, which gives you the polishing burrs also, which gives you the polishers also, which gives you the abrasive containing brush also. And in some kit, you also get, sorry, the shape guards also. So with this in one box, you get everything together. So you don't have to invest in so many things. The whole idea here is minimize the inventory, minimize the locking of your money in inventory and get it versatile. Use the same things for multiple places, for multiple things. So in one package, you get multiple achievements. So all that was with the theory. Now let's see some clinical cases. This was a case of composite veneer. a very interesting case. The case was referred to me with my from my orthodontist, and he said that I am tired of this case and I have debonded it. But even now, this lateral has still got locked out. And it was not actually locked out, it was a small rudimentary type of lateral incisor, which we could not get in the position. Now, I was talking of the zenith in the starting. Now, if you see this central incisor and this central incisor, in this lateral incisor and this lateral incisor, the gingiva are at different levels. Centrals are at different level. This lateral and this lateral are at different level. So we decided we had to change the zenith of the gingiva to some extent. So I said, okay, fine, let's do it. I marked the gums with my indelible pencil. I did some local infiltration and sorry, something happened. The slides got interchanged. So this was the original tooth and that was after the marking. Yes. And with my TCS, I had done the CLP, crown lengthening procedure. I had just made sure that I have sufficient thickness. I checked it with my periodontal probe and then I took my TCS and I trimmed it out. This central also I had touched just in overzealous way because नया नया काम होता है, new things you are getting to do and you become over excited. Over excitement makes your vision impaired. So you can see the difference between the zenith here and here. I made this mistake. I'm sharing my mistakes here. That this is what happened. This central was not required to be touched, but I did it anyhow. And central also and the lateral also. Now you can see the zenith part more or less as much as close to as possible. That kind of thing. And that is my composite buildup. Voila. Now, as I said, your finishing and polishing needs to be done. I cannot leave it like a block. Does it look nice? No, it doesn't look nice. It doesn't look anywhere like a lateral incisor. Come on, please. So I started trimming it down with my burrs. Yes. After burrs, I immediately shifted to cones. Yes. And with that, I got this finished outcome. So where we started from and where we ended. People may ask me, what is this? Because these pictures are immediate post-operative. This is the sloughing of gingiva because of the abrasive action on the cut gingiva. If you go by the previous, everything was done in one appointment. In one appointment, I had trimmed the tooth. At the same time, I had built up the tooth and I had done the finishing and polishing of the tooth. Not a very good case outcome if I see the gingiva, but a reasonably good case if I see the dental element. And immediately post-operative, this is what the photo is. A single tooth restoration compared to the adjacent lateral. I'm sure once the gingiva will heal, it will give me a very much healthy look. A very much healthy look. Another case. Now here also, I think, yeah. Here also the problem was the patient wanted only 6 teeth to be corrected. You can see the mesial angulation of the 2-1 is having slight tilt. It is not straight as your 1-1. And here also the gingival zenith was irregular. So again, the same protocol, marking how much I had to trim with my indelible pencil. With my local infill, I had done anesthetic effect. And here I had done all 6 teeth, trying to get the correction of zenith as much as possible. Now see, this patient has already got 2 teeth restored. Now when they have got already 2 teeth restored, what do I am left with? Other 4? But I said, no, I will do all 6. Don't worry. So we did gingival trimming with my PCS. After marking with the pencils, we tried to achieve hemostasis by local hemostatic agents. And that is the finished case. Now here the important thing is, one, patient wanted only 60 to be done. So I had to respect that, even knowing that only 6 teeth will not give him that beautiful result as doing 8 or 10 teeth. Because my smile window defines that I should do always one tooth extra on each side than what is visible. So if a patient is smiling and I get to see only 6 teeth, I tend to do one tooth extra, because what happens when you're doing veneers, when you are beautifying the smile, inherently you are removing the inhibition of the patient to smile in proper way. Try to absorb my words. You, when the patient is having a limitation, patient is aware of dental limitation, that yes, my teeth are not looking good, and they want beautification, and they pose for you, doctor, I want good set of teeth, and they smile. Now mine is a low lip line case, you cannot see my teeth. So they smile with inhibition, they tend to show you less teeth. So based on their smile window, you judge, okay, fine, 6 are enough. But in my opinion, when those 6 teeth get corrected, the smile becomes wider. And when it becomes wider, those extra teeth are visible. Those extra teeth which are visible spoil the beauty. They tell, this is natural, this is artificial. So my opinion, and the lesson I learned over the years, always count one tooth extra. So if the 6 teeth are visible, I count 8. If 8 are visible, I count 10. And if 10 are visible, I tell them molar to molar. And the second thing here was, first thing, patient want only 6 teeth. Second thing, patient was least bothered about the inclination of the incisors. So one half is vertical, other half is tilted. We told him, why don't you go for ortho? He said, nothing doing. I just want 60 to be done. Because 2 teeth he got done somewhere, and he had the idea what aesthetics is about. And he just wanted 6 teeth, which he wanted to show to the world. And the same we did. And the third thing, what he told me, white teeth. When you're doing a single tooth, you tend to restrict to the shade of adjacent teeth. When you're doing 6 teeth, 8 teeth, 10 teeth, you are having the whole playground. You can choose any color as per the mutual agreement between you and the patient, obviously. And so a patient who is having a fluorosed appearance of teeth, if you see the previous picture, for them, beautiful white teeth is a dream. And if you fulfill that dream, nothing is better than that. And yes, it was a male patient. So the notion is, in our society, aesthetic is sought only by females. Please, today we are more upward, outward, and even the males have so much good sense of beauty, not just the ladies alone. So I get a lot of male patients also for getting aesthetic dentistry done, not just the ladies. So the patient was happy with the smile. And as you can see now, my observation, the minute he will smile happily, one tooth extra will be visible. And that is where the whole treatment will fail. I hope I am able to put across my point by showing this picture. Let's get to another case. Now, this was a case of diastema closure. Now, this lady had come to me with a demand that all the gaps should be closed. And if you see the adjacent, I mean, from the proximal view, how extensive the diastemas were, both upper as well as lower. So to her, I advised, you get all the teeth veneered. She said, what? All the teeth? I said, yeah, all the teeth which are visible in the front, you should get them covered. That means canine to canine upper and canine to canine lower, at least. She agreed. And that is what I got for her. The finished case. It took me 2 to 3 appointments to finish all the teeth, because in one When we are doing such big number of teeth, I always go in sets. I either I do one arch at one time and second arch at second time, or I do one section at one time. That means four incisors in one time, canines in second appointment, and same way in the lower arch, incisors in one go, canines and premolars in second go. That is how it should be done. Otherwise, what happens? Patient feels fatigued, you feel fatigued, and the vision gets blurred, fingers get tired, and sometimes we just spoil. And you can see the proximals, how the diastema got closed. Yes. In this patient, I had to do 13 veneers. One tooth extra I had to do to get that harmonious appearance. And this is the finished close-up view. Now here also I had followed the same principle that your maxillary teeth are one shade lighter than your mandibular teeth. Same is visible in the picture. Maxillary shade is one shade lighter than the mandibular incisors. And the happy smile. Now again, the point proved, happy smile means one tooth extra. So make sure next time you take up a case where patient wants 6 teeth to be done, ask them at least one tooth extra. And sometime to put across your point, you may have to challenge. If you don't like it, I will make it free. That one extra tooth, I can make it free. But don't let me spoil my case because I have to put all these pictures on Instagram and on Facebook and whatnot. Social media का जमाना है. It's a world of social media today. So I'm not active on social media, but I know the youngsters, they are very much keen. So don't let your patient spoil your cases by their adamancy. Convince them. Convince them. Now this case had come to me for bleaching. I applied the gingival protection. And then suddenly I realized, oh, this is a good case. Why not take a picture? And that is why you see all these blue material over the teeth. These are nothing but gingival protection, and this blue gel, what you're seeing in between is immediately after the bleaching was done. And somehow I just felt that if I just leave this patient with bleaching, he will go outside and then tell, I got bleaching done, but my results were not good. So I convinced the patient. I educated them. I told them, see, these lines what you are seeing, I will do bleaching, okay, but they will not get eliminated by plain bleaching. No matter how much bleaching I do, these lines cannot be abolished. So the patient was confused. He said, okay, then what? I said, then we do veneers. He said, okay, fine, take them off. So I removed the material. We took a smile picture, and this is the smile he gave me. Grinding of teeth. And you can see how prominent these cracks are, how prominent these fluorosis spots are. So we said, okay, fine, we'll do veneers for you. That will give you better result. He said, okay, fine, you do it, but I have one condition. I said, what? I want super white teeth. I said, what? He said, yes, I want super white teeth because I'm tired of these brown spots on my teeth. And since now I'm getting them done, so why not get them done in a nice, grand way? I said, okay, fine, bingo. And here I was able to convince him 8 teeth. Now you saw the difference from 6 teeth to 8 teeth. I told him that, see, now you have got 8 teeth done. Why not you get lowers also done? He said, okay, let me get happy for a few days with my upper teeth, and then I will think about the lowers. So now this is the happy smile, and you can see the value of that additional one tooth on each side. I'm sure you all will agree. If I would have left it at 6 teeth, what would have been the outcome? So this was a picture perfect case, and the patient was so happy. It has been almost 1.5 years, and he has not come to me for the lower teeth. He is happy with the uppers. Most of the time, people just do the uppers and leave the lowers Some books say you can do the veneers on the upper and you can just do the bleaching of the lowers. But my problem is such lower teeth cannot be left on bleaching alone. They need touch-ups. So this was the happy patient with additional one tooth on each side. I always love to say we dentists enhance the self-esteem of the patient. This is another case who had come to me and with the finished 8 veneers on the top, you can see the dramatic change. And now this was the case of high lip line. You can see the amount of gums visible. So I had to keep my gingiva intact. I had to keep my margins equigingival, making sure I don't do any damages to the soft tissues. Otherwise, the whole case will lower. Coming to some common mistakes. We are humans. We are all humans. We make mistakes. And if we know the mistakes of others, at least we can learn from them. People say experience is an expensive book. Yes, definitely. Some experiences we learn by our mistakes, and some experiences we learn from mistakes of others. Not necessary. I do all the mistakes and learn by them. It becomes very expensive affair. Yes, a very expensive affair. So what are the common mistakes which leads to failures? Wrong case selection, psychology. A patient is not at all motivated. Wrong case for selection. Over expectations. Oh, I will get a smile like any film celebrity. Over expectations. Unrealistic desire. Teeth are proclaimed and patient wants them inward in 2 days. Unrealistic. Such cases are wrong cases. You should not select them. Oral health, especially if the patient is having habits, uncontrolled bruxism, chewing tobacco, chewing pan, whatnot. These habits are to be corrected. Otherwise, your treatment will fail. All cases of bruxism, if I get to identify, what do I do with them? I make sure they start wearing night guards. Uncontrolled bruxism, you cannot tell, don't eat from tomorrow and patient will do it as per your saying. Bruxism is uncontrolled motor function. To control it, you have to make sure you give night guard to the patient and then you take help of something called muscle relaxants for releasing the muscles in night so that they don't grind the teeth. But that is a complex topic. I will not go that side. But uncontrolled bruxism, you have to make sure either you don't take up the case or you make sure you give night guard to them to wear in night, at least. At least. And the occlusion, deep bite. I'm sure you all have experienced it. Deep bite cases are most prone for debonding. Be it your composite veneers, be it your ceramic veneers, they just pop out. Patient will come back with veneer in hand. And what will they say? I was just eating and it popped out. And you will use best of your resins, best of your cements for your ceramic veneers. You'll use best of your adhesives, incremental builders, etc., for your composite veneers. Either they will pop completely or they will break. So deep bite cases are absolute no. You have to get the deep bite corrected first. Only then think of doing your composite veneers. Another mistake is wrong shade selection. अगर shade ही गलत है तो starting ही गलत है. If your shade is wrong, then you cannot mix and match later on. It happens. We selected A2 and after restoration looks like A1. Why? Because tooth has dehydrated. In the middle of tooth buildup, if you see that your shade has changed, don't panic because tooth has dehydrated. That's why it is looking different shade. Let the teeth get rehydrated again stay for 1-2 days, and then check shade again. But in the starting, your shade selection has to be proper, otherwise, you cannot rectify the problem again. Lack of isolation, yes, saliva, blood, anything will spoil your adhesion. If you break your bonding protocols, as I said, don't let pools of bond lay on the tooth. Make sure you make it smoothly spread all over. If any pool of bond is there, no matter how good it is, it will always hamper your bonding. Instruments have to be clean. Dirty instrument will add up pigments in your restoration. So at the time when you're done with finishing and polishing, patient will say, Doctor, kala kala kya hai? What is that black spot inside the tooth? And then you will realize the dirt specks have gone inside the composite and have spoiled your restoration. Same with curing. If your curing is not optimal, if it is incured, incomplete, insufficient, it will cause discoloration at later stage. Any overzealous finishing and polishing will cause burning of the tissues, increasing temperature of the pulp, causing sensitivity and even opening of the margins where the thin composite just chips off. And last but not the least, the oxygen inhibited layer. Now this layer is very interesting. All composites have their top layer as uncured layer. I'll show you to explain it. You remember this case of the diastema, and once I had sent the patient to the home, next day she came with all these yellow spots. Now these spots are nothing but not the food stains, but because of the uncured composite. Whenever the top layer is cured, there is always some uncured composite left behind, which is because of the oxygen in the atmosphere. And this uncured composite takes up the stains from the surroundings. Whatever food you are eating, from there it takes the stains, absorbs, and gives yellow discoloration to the composite. So the composite, which was beautiful white, got stained. Now, what is the remedy? You can see still it was there. One photograph was with the chairside light, second was without chairside light, and I could see it. The solution is do the finishing polishing again and light cure it, but this time with a KY jelly. Any local anesthetic gel you can use for the purpose, just coat it the top layer and cure it. That petroleum jelly, not petroleum jelly, sorry, my mistake. That anesthetic gel or any KY jelly, any liquid water-based colorless jelly which you are taking for the purpose will inhibit the contact of oxygen with your composite and will allow 100% curing of the top layer. So I did the same with this. I took the jelly, covered the freshly polished composite restorations and cured it again. And that is how I controlled my oxygen inhibited layer. So that is the easiest way to control this layer and to minimize this post polishing staining of composites. And that is the finished polishing second time. After 2 days, the patient came back and I saw the results were stable. So that is how we manage it. Now, there are some tips for longevity of treatment. People ask me how long the treatment will last. And I say sufficiently last. Never give numbers to the patient. Never. If you keep your preparation in enamel, enamel is the best bonding substrate. So definitely your restoration will last for years. Even if you manage to get in dentine and your isolation is adequate, you will be able to give few years to your restoration. And if your light is good, curing is in a good proportion, discolorations will be minimized. Any frictional heat you should minimize. You have to give luster to the restoration, but not at the cost of pulp. What is the point of giving high shine to the tooth if your pulp gets sensitive and becomes painful? Eventually, the tooth is going for root canal treatment. Eventually, the veneer is getting changed with a crown. So you have lost the battle. So minimize your pressure. Don't do overzealous polishing. So minimize the frictional heat and always protect the margins in gingiva from any injury, either at time of tooth preparation or at time of finishing and polishing. Never, never, never lacerate your gingiva. Why? Because if you will lacerate it, it will cause bleeding. This bleeding will penetrate your composite, will give black pigmentation there, leading to failure of aesthetics. So whenever you're doing finishing and polishing, whenever you're doing tooth preparation, try not to injure your gingiva. If you are using discs, at least use them with water irrigation so that they don't get clogged and they don't lacerate your gingiva again. If you are able to manage this oxygen inhibited layer, nothing works better than that. And always we tell to the patient, don't eat colored food. So the dietary recommendation after your composite restoration for first 24 hours is only curd rice. Curd, yogurt, lassi, buttermilk, pure white milk, plain rice, curd rice, but no turmeric, no red wine, no smoking, no cold drinks, because all these will give colors. And if your oxygen inhibited layer is there, it will absorb the colors immediately and spoil your hard work. So I always conclude my presentation with this saying that if you have been doing what you have done and you don't make any changes, you will get what you have always got done. So it's always good if we think different and start acting different. Thank you.
Thank you so much, sir, for this detailed explanation and this wonderful presentation. All your tips and tricks were really very, very helpful. So we'll break down for 10 minutes, sir. You can just freshen up and then we can start with the demonstration. Till then, participants, I am posting some quizzes. Kindly
So I'll leave for
participate
the
in that.
moment and then we can join back again
Yeah.
with the hand.
Yes, yes, sir.
Okay.
Thank you, sir, for the wonderful presentation. Yes, small tips and tricks will help us a lot in the near future. And participants, please participate in the quizzes because this will help you in the rec- for the free gifts. These quizzes will be displayed. Yeah, Dr. Sneha.
Is it visible?
Yes, done.
Okay. Yeah, please
Participants,
participate, everyone.
please fill out these quiz Participants, you can post your question and answers in the Q&A section below your screen. We will take all the question and answers after the demonstration part.
ऊपर करके देखिए। हाँ,
I think it is better to focus on teeth rather than my face.
ओके, नो प्रॉब्लम सर, नो प्रॉब्लम। खेम सर फिर वैसे ही रख दीजिए। या
Yeah, much better.
यस।
So थोड़ा और पास कर सकते हो बोलिए। So if you can see here, this is my prepared food. This is my unprepared food. Now the agenda is to replicate this much as much as on the other side which I have prepared. Since it's a model extracted tooth, I may not do acid etching, but I can directly apply my bonding agent on the top, spread it evenly, and then cure it, and followed by composite restoration. So here I am using the single dose 7th generation bond, 1.7. It is said single dose, but it is sufficient for 3-4 pills at least. One has come in, taking the applicator tip and apply it over the top. Whenever you are applying, make sure you don't let any pool gather here. Because if the pool will come, then the bonding will get compromised. You can see the shiny surface followed by right cure. Bonding agent also the same principle applies. The first cure is on the inside. Then if you have shade guide, it's very easy to do the shade selection. But even if you don't have shade guide, one traditional trick is that we take different composites and these are my climatic student instruments. What we do in the absence of shade guide, we take a small increment, make it a ball, and then I place it on my tooth on which I have to do the. I place this blob on the tooth which I am taking as reference for my shade guide. And once I spread it evenly, I can see whether my composite in the tooth is having the same shade or not. Now, if you see here, it is almost same. That means this is the shade which I can use for my composite. So my dependency on shade guide is minimal. With this practical tip, I can straight away think about doing my composite builder. Now, why this material adheres to the instrument is if your instrument is not clean. So whenever you are using your instruments, make sure you clean them up with sprit gauze so that any dust, environmental dust which is there on the instrument is removed. And we always take small increments. You can see the size of my increment. I place it and with the other end, I can blend it. The sequence is very simple. We start from the labial, center part, and then go in the proximals. Why I start from the midline of the tooth is so that I know how much I have to push sideways. Any excess pressure will cause my composite to get pulled up. So I don't want that. Always start from the cervical part, never incisal. And you can see how well it adapts. Once I'm done with cervical, then I can go to middle third, then I can go to incisal third. And you can see that since my instrument is clean, so any composite is not getting pulled out. So that is the trick which you have to remember always. Clean instruments, small increments from cervical to incisal build, and the light curing from inside first, then from the top. Another tip which I give to the students is that whenever you are doing light cure, make sure your composite is closed. Otherwise, what happens is the light, environmental light, cures it prematurely. And your syringe becomes useless after a set number of uses. Now I am taking my second increment and I am doing my middle third and incisal thirds. And always make sure that your increments are not excessively thick. Otherwise, what happens is we lose on the effect of top layer because that top layer will get removed from the tooth because of polishing. I cannot make one tooth fat and one tooth thin. It has to be same size. That way, it have to be careful that your increments are in doubt. It may seem in the starting that the shades are not matching, but we cannot change our combinations in the middle. It's not that initially I take A1 shade and in the middle I feel that it is not matching and then I change my shade in the middle and then I take up another shade and another shade. We'll just create a mess. So it is always better to fix your formula once, then decide on it, use it, and later on see the effect. If still you feel that no shade has not matched, then do the repeat procedure. Otherwise, changing shade in middle of the restoration will just spoil your restoration. Now I have done my base builder. Over the top, I can use my enamel shade, translucent enamel shade to give that luster. Any remnant composite which is there on your instruments, any remnant composite which is stuck on your instrument will cause instrument to become sticky. So after every use, make sure you just wipe it up so that it remains free of such debris. Now this is my trans layer. For incisal, I am doing some irregular surfaces so that I get that translucent halo type effect. This is my trans layer. Now this layer I can cure directly from the top. Now I have to build the incisal edge. Again, I'll be going to my base shade. With that, I'll be building the palatal side. See the size of the increment. Now here, if I want to have the translucent incisal edge, then I can, instead of using my A1 shade, I can straight away use my trans shade and finish it off. But if I want an opaque incisal edge, then I have to use A1 shade. Never be in a rush to do bulk curing. Never be in a rush to do big increments. You'll just spoil it. If you take it too much palatal, you will have difficulty in finishing and polishing because patient will keep on complaining rough surface, rough surface, rough surface, which I don't want. And another thing is, it's always better to do 0.2 millimeters, 0.3 millimeters extra buildup so that you can trim it down when you're doing your final finishing. The problem comes when you are doing exact buildup. That time you don't have scope for finishing. And the patient will complain, दांत छोटा हो गया, it has become smaller. Whatever is little bit off the track, you can always do incremental build-ups again. You can take care of things. Beauty of composite is that if you leave it up without curing also, with the environmental light, it will cure out. But that takes time. I don't want that. The last trans shape just to finish off whatever is extra left out. Then you can giving those irregular depressions just gives that halo effect, the translucent halo effect. I'm just trying to give different types of effects. So my model is not going to ask about it, but yes. So I'm sure you people all might be having a lot of questions about various things which I discussed about. So let's see.
अमित सर सॉरी टू इंटरप्ट, थोड़ा सा वॉल्यूम आपका लो आ रहा है एंड थोड़ा वीडियो पे जूम कीजिए। खेम सर, थोड़ा वॉल्यूम लो आ रहा है सर का एंड थोड़ा लैग हो रहा है वीडियो।
Okay, so that was the build-up part, and let's start the finishing. So Always start with low speed. Never jump on high speed. That is the principle of polishing. We are not going to use birds here and directly using the polishing foams and cups. See how I'm moving from proximal to medial just to maintain the curvature. I can increase the speed now since I have become more comfortable. Yes. For build-up, I was going from medial to proximal, but from polishing, I'm going from proximal to medial for one reason, to maintain the curvature. Otherwise, if I go from central to medial, I will lose the convexity which I had created with my compositing. Always use brush stroke. Don't use continuously. Use brush stroke. That way, you will get the freedom of movement as well as the compose will not get flattened out. The idea here is not to create a perfect restoration, but to highlight the various problems people face, the various mistakes people do, and how we can manage them. In a clinical environment, anybody can get good results, but the problem is to know about mistakes and to know how to manage them. If at this stage I feel yes, I can further increase my speed, I can, but I have to be very sure that I don't raise the temperature. And I don't flatten my respiration. So any overhangings you have left at this junction, your burst will be the ideal instrument to remove them. Your disc, your cups, your goals will only enhance the increment which you have left on the tooth surface. Now, just to show you use of other attachments, how we use them. Somebody says that what is this shape? This is a different type of cone. We use it. I can use it for the high speed, no problem. Should not be used like this. It's always to be because the minute you touch it, you make it flat. You will not get control here. But when you will do it like this, you will have better control. And you get a broader surface to work upon. Always, always, always. To show you another attachment to polish with. That is my favorite. This shape. Now this flame shape comb also gives me access to my cervical bulge, cervical third. Very smoothly. without the risk of laceration of gingiva. Either also I can go ahead because this cone will follow the curvature of the and will not do any excess trimming anywhere. Let's shift to our shape guards. Anything new you want to use, always go on low speed first so that you have control over it. And then you can use it in proper way. I have to be sure that I don't put all these polishing agents on adjacent teeth, but unnecessarily I'll be scraping there in an allow. This is not a good thing. You can use it flat, flatten it. If you feel some spicule is coming up, you can flatten it. You want to go proximal, you can go proximal. And as you become comfortable with your weapon of mass destruction, you can see how I have refined the incisor edge from inside. I'll show again. And I can do it like this, or I can do it like this. Whichever way I feel comfortable, you can. And if I am comfortable, I can go ahead, use higher speed, but higher speed just creates more friction. So the chances of you burning the tissue increases at the same time. हम कितना तेज चला रहे हैं that is not important. हम कितना safe चला रहे हैं that is important. Composite and driving are something similar, I would say. So that was the coarse one, and we can refine further with the fine one. Whenever you're doing it, make sure you don't change your line angle, you don't change your point angle. See the left side picking up. What I'm doing here is I'm trying to minimize my oxygen inhibited layer. Instead of my water-based jelly, I am applying my bonding agent. Only catch here is that if I do that, I may impart some color to the restoration. But if you have managed your inhibition layer, oxygen inhibition layer, and then you do all this, then definitely it can work wonders. Now, some people may say that the shades are not very same. Yes, I agree here because we had applied less of A1. The idea was, as I said, not to just do a restoration, but to tell you where the mistakes happen, how to manage them. At this stage also, if one feels that yes, I want further white shade, no problem. You can take your bleach, you can take your trans, whichever shade you feel will work in the wonders for you. You can take again and do. The only advantage here is now we have already done the polishing of the base layer. So you don't have to worry much on that. Only wherever you want additional build-ups, you can do it. So composite gives us this versatility that we can add, subtract anytime we want. But one thing you have to be very sure of is the initial shade selection. As I said, if my shade selection is wrong, no matter how much I do incremental build-ups, no matter what I do, I'll always be struggling with matching the shade at the later stage. So make sure that you do that meticulously. And yes, you can achieve it. On the contrary, now I think maybe I should have started with big shade directly. Instead of going with A1, but that is how we get to understanding. Composite in ceramic, if you do this mistake, you are gone. Because the cost of repeating is high, but in composite, the cost of repeating is only your time, nothing else. So based on your requirement, based on your situation, you can do a lot of things with the composites. It's not that one thing goes wrong and it is end of the world. No, composite is very adaptable that way. And some color difference you will see because of the camera also. That is not a thing. So one thing which is most important in composite is your base layer because that will see through every other layer. And likewise, I can do again polishing to get a good finish. You want me complete it or it is okay to stop here? What the public wants. Now see, the common problem what I was talking about, one tooth getting fat from the adjacent one. That should not happen. That is why keep looking through the incisal so that you don't do this mistake. You cut down again, you build up again. Since now we know what to cut, becomes easier. So one way of finishing and polishing is you make a block and then you trim it out to the desired thickness and shape. And second is you build up exact and just finish it off. Now you can see they are not that fat. I reduce the thickness again. If you keep thinking that just at one place you create shallow craters, that will again spoil your contour of the field. Never keep them at one place. Keep rotating them. Had I had used my air rotor burst, it would have been further refinement, but you can do it other way also. Now you can see the incisal edge is almost in the same line. Yes. Higher the speed, poorer the polish, because you will lose the control on your tactile sensation, you will lose the control on adjacent areas. Personally, preference is always low speed, unless you have to catch a train or a flight maybe. So you saw I added a composite and again did the finishing polishing. Sometimes you are lucky, you get the shade right, sometimes you are not so lucky. But what is important is your patient should be happy. Because no matter what I do, if my patient is not happy, not doing anything. So this is the final armamentarium. The brushes strictly to be on low speed. They are not supposed to be on high speed. We have the final luster. That is how it is done. Now you can see the shape, you can see the shine, the gloss, the restoration. Now, just to realize the mistakes, nobody is perfect. And even with me doing so many compositor work these years, it's always there are scope to learn. Your case selection should be right. First thing, your shade selection should be right. Second thing, your increments has to be in the right sequence and in the right thickness. Because if thickness is less, the bottom layer will show the color. And your polishing sequence has to be right. Otherwise, what happens if you use fine grit before coarse grit, you will not reach anywhere. And if you use coarse after fine finish, your all luster is gone. So remember the steps, follow the basic protocols, and the chances of you making mistakes will become minimal. I'm sure there will be a lot of questions for you to ask. Let's go ahead, get them. So are we good to go with the questions or anything more is to be discussed about? Was in your- Question answered by the
Hello, thank you so much, sir. Sir, you can come on the screen now, main screen. आप sharing stop कर दीजिए.
Yeah.
Yes, sir. Thank you. Thank you so much, sir, for this wonderful presentation and demonstration. So participants, we will be sharing you the video link. Don't worry about that. There was a little video lag, sir, in the demonstration part, but I will be sharing the link for the demonstration, the entire presentation. Thank you so much, everyone. So, sir, we'll start with the question answer round. I'll just read out the questions and you can answer them one by one. Yeah,
Yeah.
okay. So the first question is by Dr. Salim Haider. Does B shade slightly grayish? What is the basic use of multiple shades in ideal tooth?
Okay. So, to what I have understood, he is asking about the bleach shade
Yes.
color question and the idea of using different shades in the single tooth. The thing is that not a single tooth will have a single monotonous shade. Every tooth you will come across will have at least 2 to 3 shades in it. It is only if we are able to observe it, we can try to recreate it. Now, when you are doing multiple tooth restorations, multiple teeth restorations, things are easy. You can paint all 6 colors, all 6 teeth in any one color, and you can get off with it. But if you are doing a single tooth, then you have to make sure as you seek perfection in your work, you have to start observing these multiple colors. Bleach shade primarily is used for masking discolorations. And that is why it is slightly grayish whitish in color so that it masks the underlying dark shades. Because if you are able to mask them, then they will not show through. Otherwise, no matter which shade you are using, A1, A2, A3, the dark shade will always pop out through your superficial shades. So when we are doing incremental build-ups, we have to understand where which shade is there, and accordingly we take countermeasures to balance it out. I hope his question is answered or he wants more elaboration.
Sir, I will check with the doc. If there is any more clarification required, I'll ask him to like send it on the group, sir.
Okay.
Yeah. Next question is by Dr. Imran Sheikh. Sir, where can we find the short burr which you'd use for demonstration? So I'll share him the product brochure, sir, for the
Yeah,
burrs.
it's there in the kit. You can always go through the kit, and even if still you can see your cavity prep burrs. It is not that you cannot use your own thinking. The Coltene kit is having maximum bursts needed available in one place. And anything extra, you can always see your inventory.
Yeah, I'll share it with him, sir. Thank you.
Yeah.
Okay. Next is by Dr. Vaibhav Kamre. What should be the ideal thickness for incremental layering?
If you're just willing to change the enamel coat of the tooth, 0.5 is more than sufficient. But if you want to address the deep discolorations of dentine also, then at least 0.7 to 1 millimeter preparation we are looking at.
Okay, sir. Next is by Dr. Vaibhav Jyoti. What is name of marking pen of gingiva and where can we get it?
Simple, your DADH indelible pencil. I just dipped it in spirit and used it. Because on gingiva,
Okay,
you
sir.
cannot use chronic
Next is by yes. Next is by Dr. Saundarya. Please tell us about composite warmer.
Composite warmers are had been in use and had been popular recently. The idea is to make your hard composite again soft and pliable. The catch is that what happens when you are using your new syringes and they are left open at the time of curing, they become hard because of the light cure as well as the environmental light. So these hard composites are difficult to adapt. Now to make them soft again, you need something to bring them at higher temperatures. So you can use your, either you get machines. Coltene used to had one such warmer, I think. Now it is not available, but otherwise you can use your wax mold melting devices, what the parlor people use. It is nothing but a hot water bath. So you can use them also for the purpose and your that hard composite will become soft again.
Thank you, sir. Next is by Dr. Shihib. Is vertical height necessary during both jaw smile design? During both jaw smile design.
I am not getting the question properly.
Is vertical height necessary during jaw smile design, sir? Like smile designing, does vertical height play an important role?
One thing we have to understand is there any loss of vertical height in the occlusion? Second is how much is the freeway space available? Because if I make my incisors long, there will be two problems. One, it will hit, the incisors will hit on the lower lip, causing difficulty in pronunciations, lip traps. And secondly, if the freeway space is less, then your incisors will break. On biting, on chewing, your incisors will hit between each other and they will break. So always calculate whether there has been any loss in the vertical height, then you can increase it. If there is no loss in vertical height, you don't have to change the length more than 1 millimeter on the higher side because your freeway space is 2 millimeters. So 1 millimeter I can still play with, but not more than that. And in case if I want to make my teeth look longer, I can use optical illusion rather than increasing the physical height in actual. I can make the teeth appear slightly slender, slightly thinner, less broad, and I can give the same effect. I don't have to play with the freeway space also in that way.
Okay, sir. Next is by Dr. Pragati Barge. How to avoid line that differentiates composite from anterior to basically the demarcation line she's asking about. How to avoid demarcation line.
Can you repeat the question, please?
Sir, Dr. Pragati, she is asking how to avoid line that differentiates composite from anterior to. Basically, she's asking about how can we
Finish
avoid the
line.
demarcation line. Yes.
Yeah. So you have to first understand which type of smile window you are working at. Either you are working at medium or you are working at high smile line. If you are working in high smile line and your gums are also visible, then keep your margins equigingival. That way, the junction between composite and tooth will not be visible. If you will keep supragingival margin, then make sure that smile line is not showing more than half of the teeth. That way you can make out. And still, if you want to mask up, you can just do a fine bevel on your finish line and give that in a bevel coverage with the material. It is a bit difficult to understand, but think that you have prepared a margin, there are sharp butt joint, and that butt joint you are leveling up with a fine burr to create a small bevel just to mask the finish line. That way you can mask the finish line of your composite and cloth junction.
Okay, sir. Next is by Dr. Joel Verghese. Sir, what about using a single shade composite like Omnichroma from Tokoyama?
Anything which works for you should be good enough. But when you are using something, you always realize the lacunae, the limitations, and that is why we look for better things. There are a lot of companies who say that there are two dual shades in their single syringe. I have worked with a lot of them and I came to the conclusion that what works for me is brilliant. What works for me is brilliant Everglow, and that is how I have stuck with this composite now. It's
Thank
been
you.
20 years I have been playing with composites after my post graduation. So you can understand how many composites I have tried and tested. Whatever works for you works for you. It is not that what works for me will work for everybody. But yes, I can tell what works for me, and then that is your cue.
Yes, sir. Sir, next is by Dr. Sangamitra Yadav. She's asking for link for true light shade selection.
Uh,
Link.
sorry.
I also didn't get. She's asking for link for true light shade selection. I
True
guess,
lights.
huh?
Yeah. One thing you can do is you can use your camera, either mobile camera or DSLR camera, if you don't want to invest in those lights, or you can check on Amazon. You can find them because personally, I have also not purchased them so far. How I am managing is I am using my intraoral camera, I am using my mobile camera, and sometimes DSLR to do the final shade selection, and that is how it works for me. Textbook says that they are available, but I am still to see the actual one. Maybe in any of the trade exhibitions you can try, or Amazon is the place.
Yes, sir. Next is by Dr. Pragati. Curing time and distance for composite. Like how much distance should we maintain and the curing time?
Your light should be as close to composite as possible for one, but should not touch the composite. Otherwise, your composite will get stuck to the light and the intensity will reduce. That is one thing. Second thing, your first increment has to be cured from the opposite side. So that way, the light has to touch the opposite side of the tooth. Only then you will get sufficient curing intensity. And the duration of curing is 30 seconds for a composite increment of 2 millimeters and 20 seconds for your bond. Most of the lights have set timers of 10 seconds. Every 10 seconds, they give a beep sound so that you know that one increment is, I mean, one round of 10 seconds is over, second is over, third is over, and that you can calibrate it.
Yes, sir. Again by Dr. Pragati, how to use brushes in composite.
Brushes are indicated where you are using flowable composites and you want to adapt that flowable composite in a particular area. Because thick consistency composite, you can still use your composite instruments, but when you are playing with flowable, you need brushes for them. And the idea of using brush is to make sure that you wet your brush with your bonding agent, then play with the flowable to spread it out, to pack it in one area, to build up any line angle with the flowable. That is how the brushes are used.
Yes, sir. Next is by Dr. Shihab. During aesthetic design for anterior teeth, which shade and layer is preferable? Monolayer, bulk, or sandwich?
It depends on how many teeth we are changing. If you are changing 4 teeth, 6 teeth, 8 teeth, you can go for monochromatic also and just do the incisal edge translucent effect. Or if you are doing a single tooth, then you have to follow what shade pattern the adjacent teeth are having. The same, try to mimic as much as possible.
Yes, sir. Next is by Dr. Nakshatra. Some information on different bands used for maintaining natural gaps between teeth. Matrix band she's asking about.
For anterior, posterior, because
Between natural,
because for anteriors we don't recommend any matrix bands. We just say that use your mylar strips with your flowable and bonding agents. Just adhere them, adapt them, and then with that build up the increments.
okay, sir. Uh, Next is anonymous. When should we cure with the water-based gel before finishing or polishing? After it to avoid the oxygen inhibition layer from being uncured.
My say you can do it both times before finishing polishing also and after that also. No harm in that. Because when you're doing before finishing polishing, that time also the topmost layer will get cured. And after finishing polishing, whatever the top layer is having remaining uncured composite elements that can be taken care of afterwards also. So if you do one time or if you do both times, it works. But it cannot be that you do it before polishing and later on you don't do it. What I want to say is that after finishing and polishing, putting the water soluble gel over the top and curing is a must that cannot be escaped. Rest you want to do before finishing polishing, that is up to you.
Okay, sir. Next is again anonymous. If cementum is exposed for high smile line and when we prep for veneer, you said we have to use RMGIC as first layer and then go with 7th generation bonding agent later. Could you elaborate more on it?
See, if the cementum is exposed, that means the gingival recession is there. Now the point is whether you want to recreate the gingiva part or you want to create the composite part. In any of the case, the substrate has to be made favorable. So cementum has to be first coated with resin modified glass ionomer as a base layer, and over that the 7th generation bond. And over the top you can use either gingival shade or a tooth colored shade depending on your requirement.
Okay, sir. Um, Next is by Dr. Bala Selva Kumar. Sir, can you share idea about fabrication and bonding of temporary veneers? I had done temporary veneers and bonded with spot edge and flowable composites, but patient repeatedly complains of fallen temporaries.
You need temporaries for ceramic veneers, and in that case what we can do is uh, most of the time the problem is the same problem happens with everybody. What I say is that dilute your bonding agent with alcohol spirit so that the adhesion power becomes a bit less, and with that you do adhesion of your temporaries. So when this is done, it is a bit tricky procedure, but since the strength of the bonding system is diluted with the spirit, so chances of taking your temporaries off becomes easy. At the same time, their retention in the mouth increases. I know it is a tricky situation. Because if you use straight away bonding system to adhere your temporaries, they will not come out. You will have to break them off. And that will change the dimension of the prepared tooth. So it is better to use bonding agent in dilution so that the adhesion power reduces and you can pull off your temporary easily.
Okay, sir. Next is anonymous. Is it always advised to apply water-based gel before curing the topmost layer?
You can use your bonding agent also, but the chances with the bonding agent is again that some percentage of resin will remain uncured. And that is why most of the speakers today prefer a water-based gel as the layer for preventing the inhibition layers.
Yes, sir. Next is by Dr. Shihab. Sir, you have shown us only incisor preparation for veneers. Rest of the teeth like premolar, lateral incisor, and canine, is it the same protocol or different?
I had shown one case of diastema closure where I had done till premolars. Sorry, that was still canine. And one case I had shown where patient had got 8 supervised.
Eight.
So when you are doing canine, the protocol is same as your incisors because canine is not in occlusion like a premolar. It is more like incisors. That means the palatal surface is having point contacts. There is no surface to grind upon. But when it comes to premolars, your preparation will limit itself to non-contact areas like a 3/4 jacket crown. You cannot bring your preparation to occlusal contacts. Otherwise, your restoration will fracture. That means when you're preparing your premolar, you have to make sure you take occlusal contact points and keep your margin away from it. You cannot have edge ending preparation there. You have to have edge overlap. That means your buccal cusp has to be covered with composite and your preparation has to end away from the occlusal contacts.
Uh, Next is by Dr. Bala. Sir, can you mention indications and contraindications of composite versus ceramic veneers?
Every indication of composite is indication of ceramic. The contraindication is your patient doesn't want to pay. So you cannot use ceramic. And when patient wants extra long life of the restoration, then you, for their sake, you have to advocate ceramics because average life of ceramic is claimed to be 8 to 10 years and for composite it is 5 to 6 years. I have seen composite restoration lasting more than that. It is not that they cannot last, but we never give a number to our work that it will last this many times, this many years, this many months. No, because unpredictable things are not in our hands. And patients are very much expert in getting hold of our neck if we say, ये इतने साल चलेगा, ये इतने साल चलेगा, and then things happen unexpectedly. So contraindication of composite is when patient has higher expectations and you are not having trust on your abilities. Ceramics are advocated when patient has higher demands, they are ready to spend for it, and you also know that doing composite for them will not justify their need. I mean, it is not that composite is anyway inferior to ceramics. It is just that for patient psychology, sometimes for psychology's sake, we have to take decisions.
Okay, sir. Next is by Dr. Shihab. So he really liked your presentation and he wants you to have a he wants you to conduct a presentation in Bangladesh. So he's like, Bangladesh people would really benefit from this such type of webinar. So he's requested for you to present there also one time.
I can come as long as the logistics are worked upon.
Definitely, sir. We will work on this, sir. Next is by Dr. Bala. Is immediate dentinal sealing needed or not needed in indirect restorations?
In indirect restoration,
Yeah.
dentin has to be sealed. Suppose I'm preparing inlay, a ceramic inlay. If I prepare the tooth, that dentin is exposed. If I leave it as it is, that dentin will become sensitive. So even if you are getting a ceramic restoration fabricated or making a composite restoration made, the dentin has to be sealed immediately. You cannot leave it open. You can seal it with help of your bonding agent. You can seal it with help of temporaries. You can seal it with your material, but you cannot leave it open. Any cut dentin, you leave it open, the tooth will turn sensitive. Patient will have nightmares.
Okay, sir. Next is again by Dr. Bala. Sir, does bleaching agent affect bonding in indirect veneers?
Sorry?
Does bleaching agents affect bonding in indirect veneers?
No. It may dehydrate the tooth. Whenever we do bleaching, it dehydrates the tooth. It opens up the dentinal pores, enamel pores, because it is a kind of acidic environment for the teeth. So dehydrated teeth definitely are more porous, but if you are following your bonding protocols, if you are following the instructions of the supplier, manufacturer, then the chances are that effect will be minimal. And if you are thinking that I do bleaching and then do prep and then I do the cementation, altogether it's a different thing. But if you think I have done the tooth preparation, I have taken impression, my veneers have come, and now for sake of bonding, I do bleaching. No, that is not indicated. That is not indicated. I had shown one case where I had done bleaching and then I had done composite restoration. The only benefit I got was the enamel pores were open, the debris were open, but then I had to prepare the teeth so that advantage had neutralized. So whenever you are doing bleaching, the tooth becomes dehydrated. Enamel, yes, it helps, but dentine, it doesn't help.
Okay. Uh, Next is anonymous. How to decide if we have to include or not include contacts and incisal edges?
For that, you have to understand whether the existing contacts are adequate or you want to change them. Suppose there is gingival recession, the papilla has resided, you are seeing black triangles between the teeth. So that point, my say is, it is better to change the contacts, and that is where you open up the contacts. But if the papilla are at right place, there is no black triangle, and the teeth are having a healthy contact, why to disturb it? Got it? I have to disturb the contact only when I can improve it, or when I feel it is important to improve it, not otherwise.
So next is there any waiting period between bleaching and bonding of veneers?
If after bleaching you are doing tooth preparation, there is no waiting period. Just a minute, please. If you are doing bleaching and doing tooth preparation, there is no waiting period. But if you are done tooth preparation, then you don't need bleaching to be done again. I hope I am clear enough on it.
Next is by Dr. Bhavna, sir. How to do preparation in diastema or open contact cases?
In open contact cases or diastemas, one thing you have to see is how big is the gap. Because if the gap is excessive, we can only minimize it, we cannot eliminate it. And in that case, since we are going to develop a contact also, the preparation will go slightly palatal. It has to go slightly palatal, and that is how we build it up. Creating the contact between two adjacent teeth having diastema in between, you have to do incremental buildup on the proximals of both the teeth, and then finally separate them out with mylar strips. Stabilize the mylar strip with your flowables, then do the final contact buildup with your composite. And once that is done, then you can remove the strip and do the restoration complete.
Okay, sir. So for how long the polishing has to be done to avoid sensitivity?
Polishing has to be done to achieve luster, to achieve gloss, to achieve smooth surface. It has nothing to do with your post-operative sensitivity. Post-operative sensitivity is happening only because your margins have opened up, because the restoration from the margin has chipped off, or because of faulty curing, it has already got gaps in between. Polishing has no relation of it.
Okay, sir. Does the zenith point regrow after resection?
Sorry,
Does the zenith point regrow after resection?
slightly. And that is why we always cut a bit extra, because the natural healing thus brings it to some extent, but not that much as we had cut. I mean, I had shown my first case how much I had cut, but after finishing, I was sure that it will not grow to the same level as it was original. That means if I have cut down 1 millimeter, I know it will grow back to 0.2, but it will not grow to 0.5 or 0.7 or 0.10 again.
Yes, sir. Sir, kindly share curing protocol even in simple restorations.
Curing protocol for simple restoration is when you have done bonding, the same opposite side of curing. When you have done the first increment, that time also the first 10 seconds, 20 seconds, you have to do it from the opposite side of the tooth. That way the material adapts completely to the tooth and there is minimal scope for post-operative sensitivity. And that is how you build it up and do the incremental curing and incremental build-up. Just a minute.
Okay. Next is by Dr. Pragati, translucent, opaque, enamel, and dentine shade difference between all four.
Sorry. Can you repeat the question, please?
Yeah. Next is by Dr. Pragati. So she wants the difference between all the four shades like translucent, opaque, enamel, and dentine shade. What is the difference?
Opaque shade has masking agents. That means the pigments are very dense and the purpose is to mask anything dark underneath. Translucent is having shade which is translucent. That means the filler particles, the pigments are having glassy color, see-through effect. So anything in underneath the translucent will be visible as it is, but with a tinge of gray. And A1, A2, A3, these are pigment shades matching to the different shade systems of the tooth. Like A2, it is more resembling the dentine color. A1 is more resembling enamel color, depending on what type of shade matrix the natural tooth is having. And translucent is always the topmost layer and the opaque layer is almost the innermost layer.
ठीक है ढूंढो मैं करती हूँ continue. Sir, how to minimize the shrinkage of composite?
First thing, curing from the opposite side. Second thing, smallest increments possible. Don't think that 2 mm cure hota hai to 2 mm karna hai. Start with 0.5, 1 mm increments. It will take some time more, but you will minimize the shrinkage.
How to bond on dentine? Please explain the protocol.
For dentine, you don't have to etch. So your total edge concept works on enamel. For dentine, what we do is we do conditioning. The same acid which you use for your enamel, it can be applied to dentine for conditioning, but only for 5 to 10 seconds. And wash it off. Don't air dry. blot dry. Use your tissue paper to dab the dentine dry. Once done that, apply your bond. Let it seep in the dentine for 15-20 seconds, 30 seconds. Once you are done with that, air chip syringes, chip syringes are better than three-way syringes, chip blowers, which you are used in college because they don't have oil in it. Your three-way syringe will have oil, which will disrupt your bonding. So I always prefer using chip blowers to blow off any pool of the bond over the dentine, and then you are doing light cure. With that, you are ready with addition with the composites.
Yes, sir. Sir, please explain how to avoid oxidation while curing. Is it possible to know about oxidation spots while curing?
Oxidation you cannot prevent while curing. That is the oxygen inhibited layer which caused staining of composite. That too because the topmost layer was uncured. In curing, whatever you are curing is getting converted from monomer to polymer in one go. There is no concept of oxidation at that moment.
Some bonding agents have yellowish color and become more yellowish over time. How can I overcome composite mapping mark?
I didn't got the question.
Some bonding agents have yellowish color and become more yellowish over time. And next question is, how can I overcome composite mapping mark? Basically the demarcation line again. The same question.
Dentine bonding agents are dark colored because of the solvents, the compositions of different components, and they turn darker with time because they lose moisture. They become viscous. As they become viscous, the solvent has reduced, and because the solvent has reduced, the color of pigments become more pronounced. So my say is whenever you are using bonding agents, keep them covered away from light so that their solvent doesn't evaporate, they don't become more viscous, and that is how you can avoid their color getting darker. And masking the margins, the easiest way is to give bevels. Whether we do a class 3 or class 4, the demarcation line is merged with the composite by help of long and short bevels based on tooth structure available.
Thank you, sir. I'll continue with the questions. Next question is by Dr. Pritinder Jeet Kaur. How does curing technique lead to discoloration?
Curing technique leads to discoloration when you're doing bulk curing, for one, because bulk curing will always leave a chunk of composite uncured, and that uncured composite will take stains from your food and surroundings and get discolored. Second is if you are doing curing and the last layer remains uncured, as it happens, and you have not used a water-based jelly over the top, then also the composite will discolor. So if you take care of your bulk curing and instead of bulk, you do incremental curing, chances of discoloration get minimized. And once you are done with composite restoration, then you do a top layer curing by using the jellies over the top, and that helps.
Thank you, sir. Next question is by Dr. Kapil Shankwar. Wetting agent for composite is mandatory. Which and where to buy?
Wetting agent means what exactly they want to know. I mean, wetting agent is agent which helps the material to spread evenly on any surface.
Hmm.
For that, we are using bonding agent. Use of bonding agent on enamel makes composite adapt better to the enamel surface. And if you are talking about instrument, then you can use the same bonding agent to dip your instrument in and then use composite. And if that is an expensive thing to do, then you can use the spirit, ethyl alcohol. But that ethyl alcohol will not eliminate the need of your bond.
Thank you, sir. Next question is by Dr. Joel Varghese. Sir, tooth preparation for composite and ceramic veneer, is it same?
More or less. But again, depends on what is our objective. If we are just trying to change the color of enamel, then a thin preparation will work in both the cases. But if we want to do some drastic changes, then definitely the thickness will change. And yes, when you're doing ceramic, your preparation cannot be less than 5.5 millimeters, because in ceramic veneers, you have two components. One is coping, and over the top, there is ceramic. So you need to have space for both coping and ceramic. Otherwise, your veneer will become thicker and patient will complain. Lips have come forward. The lips have become protruded. You don't want that to happen. That is why ceramic demands more trimming. At least 0.3 millimeters is excess trimming when it comes to ceramic compared to composite for the same situation.
Thank you, sir. Next question is by Dr. Siddhanagowda Patil. Demarcation line even after proper beveling in class 3 anterior post filling.
If you are given the right bevel and your material has blended, the possibility of having a demarcation line becomes minimal. And as I said, sometimes the patient is highly demanding. So in that case, if after repeating it once also the problem is same, that means your bevel has to be increased further. If the bevel is short, the marking will be visible sooner or later. But if the bevel is a long bevel covering major chunk of the tooth surface, then the blending becomes more harmonious.
Thank you, sir. Next question is by Shaha Imran Sheikh. Sir, how to minimize the post filling sensitivity?
Once you have done the restoration and patient is complaining of sensitivity, what I recommend is take a very fine round burr and just revisit the margins. Don't touch the tooth surface, just trim the restoration margins. Place some bulk composite, I mean, any your hard composite or flowable composite, whichever is possible. Flow it, again cure it, and seal it. The sensitivity is because margins are open somewhere. So you have to reopen the margins again and fill them up with a composite, suitable composite, and cure it.
Thank you, sir. Next question is by Dr. Kapil Shankwar. Any loss of properties of composite in warming and cooling cycles again and again in composite warmer?
When you're doing warming and cooling, pliability of composite changes. So I am not sure of any research which is indicating loss of handling properties, but we have to see. I have to find out in the literature. Because as such, if we see the practical aspect, continuous heating and cooling will break the monomers inside the composite. So we don't recommend heating the full syringe and then keeping it back in the fridge. What we recommend is use only a small increment, heat it up, and use it and finish it.
Uh, so next question is by Siddhanagowda Patil. Most of your cases are fluorosis patient. Does longevity of composite is concerned in relation to healthy tooth?
If I'm getting the question right, he is concerned that what will be the longevity of composite in a healthy enamel and what will be the longevity in a fluorosed enamel.
Yeah.
My area is a fluoride belt. That is why most of my cases were having fluoride spots. One thing. Secondly, fluorosed enamel has compromised properties, so the longevity of restoration will be less compared to a healthy enamel. For fluorosed enamel to bond, I need to spend more time on etching and more time on bonding protocol. Only then I can compete it with healthy enamel.
So next question is by Shaha Imran Sheikh. Which Sir, which kind of etching you prefer?
I believe in keeping margins and my preparation as much as in enamel, and that is where total edge concept works for me. But sometimes preparation does goes in dentine, and then when I get to know that I'm in dentine, I do total edge for my enamel area and self edge for the dentine area.
So next question is by Dr. Mohammad Fariduddin. There is any limitations for digital shade guide?
No, I don't think so.
Uh, so next question is by Dr. Siddhan Gowda Patil. Can we do FMR with composites?
Yes, you can. There is no problem in that. The only thing is you may have to go for indirect composites also in the posteriors. Anteriors, there is no issues. You can use direct composite easily.
So
Like
next
spiros you
question.
can use for posteriors.
Okay. Thank you, sir. So next question is by Farhad Sam. When should we cure with water-based gel before finishing and polishing or after it to avoid the uncured oxygen inhibition layer?
This is a repeat question. I had already answered it, but I will repeat my answer again. Using water-based gel and curing the top layer is a must after finishing and polishing. If you want, you can do it at the time when you are done with your incremental build-up and you are shifting to finishing and polishing. That time also you can do, no harm in that. But after finishing and polishing, definitely you have to do it.
Right. Next question is by Dr. Nikita Dubey. Sir, in minimal invasive restoration, do we need to sandblast our preparation?
You need to sandblast it if you are not acid etching. Some way of creating surface roughness is always essential for your restoration to adhere to the tooth surface.
Okay. So next question is by Shagun Katoj. How to stabilize the mylar strip with flowable composite?
You adapt the mylar strip to the tooth surface and just flow the composite, joining the mylar strip and the tooth and light cure it. Once you get the right shape, you light cure it, the mylar strip will retain its position and shape.
Next is by anonymous attendee. What if we use self etch on enamel?
You can use, it is a weak acid, it will open up all your enamel tubules, it will remove your smear layer. But if you think that unprepared enamel you use it, it won't create much effect because you don't have any surface damages on the intact enamel. You have to prepare enamel only then you can get the results of any bond for that sake.
So next question is by Dr. Sanjay. Which type of laminate is the best, butt joint or V shaped?
It is case situational, depending on your smile line.
Next question is by Dr. Himanshu Goyal. Which brushes, brand or type are good for composites?
Painting brush, your painting brush is more than sufficient. You don't need any specific brand for it. Preferably zero and one size.
So next question is by anonymous. Is composite favorable for pedo patient case of enamel hypoplasia pitting in the upper arch? Mother got treated for TB at birth.
As long as the child is cooperative, you can use it.
Next question is by Aisha Akhtar. Sir, can you please repeat curing of composite and posterior tooth? It's already done.
Once you have done the cavity preparation, isolate it, remove all surface debris. For enamel, do total edge. For dentine, you do self edge. Once done that, light cure,
from the-
followed by incremental buildup.
Thank you, sir. So next question is again by anonymous. Uh, can we use our tooth preparation burr for finishing, and how we get that lustre after composite veneer?
What you use for trimming the tooth for gross reduction, how can you use it for finishing and polishing? You will lose the control. You will end up trimming more than what you wanted. So no, finishing burrs are definitely different. They are fine grit diamonds. If you are thinking of using burrs, I don't recommend coarse cutting burrs for the finishing and polishing. And to get the luster, you have that shape guards, yellow and then pink and then green and blue. And then you also have that abrasive coated brushes. They can give you all the luster you want.
So next is by again by anonymous. In class 3 palatally approached, if thin layer of healthy enamel remains, it has to be kept or included in preparation.
In palatal side, if you have a thin layer of healthy enamel, preserve it. Nothing is better than that because it will give you support for your material. It will help in getting a good adaptation.
So next is again by anonymous. Role of unfilled resin.
Roll of unfilled resin is only for giving final top gloss. Once you have done all the polishing, you have done the final curing to control your oxygen inhibited layer. After that, you want more shine, maybe then you can use unfilled resin as the top gloss. Otherwise, there is no other role.
Next question is by Joel Varghese. Sir, what is the size of depth cutting burr in composite and veneer prep?
There are different grades available. You can use each of them as per your requirement. 0.3, 0.5, 0.7. Different thicknesses are available. So where you want shallow preparation, you can use 0.3. Where you want deep preparation, you can use a bigger size.
So next question is by Dr. Mahabubul Hussain. Which generation bond you prefer for denting in case of composite veneer?
7th generation. The one which I showed today.
So next question is by Dr. Nikita Dubey. Sir, there is radiolucent line between my restoration and tooth surface. How to correct it? We have already discussed this.
Redo.
Demarcation line.
Adolescent line means gap. Gap means you have to drill through the gap, fill it again, cure it, and come back.
Next is by anonymous attendee. Sir, can you please explain the tooth preparation for open contacts again?
When there is a diastema which you cannot close, and you have to prepare the tooth for getting a veneer, you can keep the proximal margin either superficial or till the middle of the proximal area. You don't have to go palatal or lingual in that case. So it is like having a middle preparation, stopping your preparation in the middle of the proximal. Why? Because you need a good retention also, and you want to mask the effect of your restoration also. You don't want superficial margin which can be seen by anybody just like that.
So next question is by Farad Sam. After restoration, is it advisable to do the finishing and polishing immediately or a day after or so?
The first phase you can do immediately, and afterwards, if your patient can come back again, you can do it again. The idea is very much same that in the second phase when you are doing, you get to know about the oxygen inhibition layers, you can take care of it. Also, at that second session, the color of the composite has become stable because teeth have become rehydrated again.
Next question is by anonymous. Does the zenith point regrow after resection?
It does regrow 0.2 to 0.3 millimeters.
Next question is by Dr. Mohammad Fariduddin. What is the chameleon effect in composite shade selection?
Dual tone in one syringe is the chameleon effect, where one syringe can give you 2 to 3 shades.
Uh, Pragati Barge is asking best curing gun brand.
Spec 3.
Thank you, sir. Uh, the next question is by Siddhana Gowda Patil. Please tell us on isolation in proximal areas like proximal strips. What is your recommendation?
The question is a bit tricky. Proximal area isolation can be done with mylar strip. Proximal area isolation can be done with your rubber dam, depending what exactly you want to achieve. And if you want proximal protection for trimming the bus, you have metal stripes also available in market, which you can use to protect the trimming of the adjacent tooth.
Uh, then there is an anonymous attendee who is asking all Coltene products for composite restoration.
I
This
think
is
you are better person to answer that.
yes, yes. Uh, then there is again one more anonymous attendee who's asking if cementum is exposed for high smile line. Okay, this is done. Sorry, these questions are just going up and down for a second. We have reached. Yeah, Pragati Barge is asking what is composite base.
Composite base is nothing but the opaque layer, which you use as the innermost layer of your composite veneer or composite restoration, I would say. The idea is to use that to mask any dark color of the tooth which is present after preparation.
So next question is by Dr. Nikita Dubey. Sir, in dip margin elevation, I get radiolucency in my radiograph. How to get it correct?
Radiolucency means your material has not been there, or you have used a material which is having radiolucency instead of radio opacity. So I have to check again whether there is a material gap or it is because of the property of the material that it is showing radiolucency.
Uh, Next question is by anonymous. For how long the polishing has to be done to avoid sensitivity?
We had answered it again, but the
Yes.
sensitivity is because of the open margins, which you can close by using sealants like bonding agents, flowable composites, and polishing you do till you get the desired luster.
Sir, next question is by Siddhana Gowda Patil. Hand instrument for composite handling. LMRT are very expensive. Any other Indian brand?
Build up the inventory one at a time. I know all good things are expensive in life, but cheap instruments you can try. But only thing is you have to keep wiping them with alcohol gauge, alcohol gauze, so that it keeps getting clean and you can use it.
Sir, I think we have completed almost all the questions. Dr. Sneha, can you see any unanswered questions at your end? Because mine it's showing completed.
No, all are done, doctor.
I still see
Yeah,
one
okay. We have a
question.
last question by Dr. Farad. Why does the patient has pain after restoration only on biting hard food?
There are eccentric high points, and that is why the patient is having pain on biting. Those high points have to be corrected. Also, have to see the contact of material with the pulp horns. Have to judge that part also.
So we have completed all the questions. Thank you so much for answering all the questions, all the doubts. Most probably have been cleared. Also, so we would request you. We will add you in the group if someone has any questions or relate. They want to show their cases. You can. You are the best person to guide them.
Sure.
Yeah. Dr. Sneha?
Yeah, thank you so much for this wonderful session, sir. You're already added in the group, sir. So if there are any upcoming questions which the participant could not ask during the webinar, so they can post it on the group and then accordingly we can keep answering them, sir. Thank you so much, sir, for this wonderful presentation. The demonstration question answer session was really very good, and I hope all the participants had their doubts cleared. And it's a pleasure to have you on board with us and for conducting such a wonderful webinar. Thank you so much, Kim sir. He's from the Coltene team from the Central Zone, and Dr. Darshana is always there to help. So thank you so much, sir.
Thank you,
Thank you,
sir.
everyone. Everybody has put a lot of hard work. I thank Coltene for giving me this platform to share my knowledge with all of you, to participants, and to you all. And I am there to help whatever I can, always with the Coltene. Thank you.
So
Thank you, sir. Dr. Sneha, please inform them about the certificates and the recording part, and we may wind up.
yeah, so participants, like within 3 to 4 days, I will be sharing you the link, the drive link for the webinar recording because it's a big recording. So at least 2 to 3 days for the editing, and we will be sharing it on the group. And the certificates also in the drive link, individual certificates will be posted. So this will just take 4 to 5 days. So be a little patient, but we will be sharing all the certificates once they are ready according to the names. And thank you so much. And I'll be sharing the recording also. There were a little disturbance during the demonstration part, so we will be sharing the drive link as well. Thank you so much for
Thank you, Dr. Sneha, for all the coordination and all the
attendance,
help.
and have a great day, all of you all. Thank you so much, Dr. Darshana. Have a nice
Thank
day,
you.
everyone. Thank you.
Yeah. Thank you.
Yeah, bye.
Record.